Again to the second Neonatal NeuroCritical Care Symposium here at the University of Maryland. We are quite happy with the turnout, and I hope everyone is enjoying all these interesting topics and discussion. Please remember, the more questions that you ask, the more engaged you are with the presenters, the better in terms of learning and enjoying this. So without further ado, Dr. Steve Thompson.
Hi, everybody. I'm Steve Thompson. I think most of you know me from the consults over the past few years. I'm going to speak today about neonatal seizures. It's a pleasure to be here. I think it is fantastic, the work that Natalie Hunt and Joanna Diaz have been doing to spearhead this neonatal critical care effort of ours. I think there's a lot of potential. I think we can really do some good clinical research and provide excellent clinical care together as a team. So with that, let's talk about neonatal seizures and what are our objectives today. Well, I would like for people to be able to recognize what in fact is a seizure in a neonate. And we're talking, the newborn until 28 days, not the older infant. I'd like people to understand that there are many different causes and what those causes might be, and how do we initiate the evaluation of neonatal seizures? What are we looking for? How do we target our diagnostic evaluation? Because the more you're targeting directly what you're thinking might be wrong, the more specific you can be, the more likely you are to come to a diagnosis. And as you'll learn, we really try to target the treatment to the etiology of the seizure. And we'll get to talk about more about that in a few moments. I'd like people to understand the initial and longer term management of neonatal seizures. And by longer term, it's not what you think of as longer term any longer. We are doing much shorter term management of neonatal seizures for many of our patients. And it's important as we finish the talk to understand the prognosis for neonatal seizures, because what we're dealing with here is a newborn and a new family, or a newborn added to an existing family of other children. And one of the main things that the parents are going to want to know is why the baby had the seizures, but also what do these seizures mean for my child as they get older? Will these seizures persist? Will there be neurologic consequences, what have you? So it's very important that we understand the prognosis so that we can give the best education to the families to help them be prepared going forward. So with that, we will talk about what it's like to be a neurologist in the neonatologist's world. As you see, we have reflex hammers, we think about the brain, and you've got this little patient sequestered in an isolette or in a warmer or what have you. And, when we're seeing patients on the floor or in the office, they're wide out in the open. They're easy to examine. They're bigger, and they can follow directions. And we can do an exam by asking them to do things. And it's not anything like that when we enter the world of the NICU. In fact, when we have rotating adult neurology residents with us on our service, there's a bit of shell shock that occurs when they enter a room with a neonate and see us do an exam on this tiny little person and actually be able to do what a neurologist does, but in a smaller fashion, and come up with a diagnosis, come up with localization of where deficits might be. So it's very important. I happen to have been trained by a neonatal neurologist, so I've been sort of hanging out in NICUs for the past 30 years. So for me, it's kind of like a second home, but for people who don't do it often, it can be quite challenging to adjust. So let's talk about why our neonatal patients are having seizures to begin with. What is it about neonates, whether they be term or preterm, that leads to seizures? What is their neurophysiology and how might it be different from older children and adults? Well, it's in fact true that immature brains are not fully myelinated. And we don't have in the immature brain, in the neonate, complete formation of dendrites and synapses. So basically what this means is that we're seeing patients whose seizures are focal, by far and away, the vast majority, almost 100% or close to it, are going to be focal seizures. We also know that in the immature brain, there is an imbalance between excitation and inhibition. GABA aminobutyric acid, or GABA, is the primary inhibitory neurotransmitter that lives in our brains and is supposed to do its job and to inhibit signaling. There is a different response in the immature brain versus the mature brain. And in fact, animal studies have shown that GABA can in fact cause depolarization of hippocampal CA3 region neurons. And there are age-related differences also in the substantia nigra in its response to GABA, both to agonists and antagonists of GABA. So there is a physiologic reason for the seizures that is innate in the substrate of the newborn, not just what's happened to cause the seizures, but the child themselves is already at risk for seizures simply because of their neurophysiology. I have to figure out how to advance the slide. Hang on, there we go. So what is the epidemiology of this and what are the etiologies? Okay, so seizures are more common in the neonatal period than at any other age throughout the lifespan. And the range for incidence is anywhere from 1.5 to 5.5 per thousand newborns, and more likely higher in our premature babies. And that's important. So it's not an insignificant number when you're looking at a NICU such as ours with the potential for 52 patients at any one time, and how many patients come through that NICU every year. Approximately 85% of neonatal seizures are provoked, meaning they come with an identifiable etiology. You can put your finger on that etiology and say, this is what's wrong, this is what we need to treat because this is what's causing this baby's problem. Now, for the other 15%, by far and away, you're likely dealing with an epilepsy syndrome, and we'll talk about that momentarily. So I have taken some cartoons and figures from publications from the International League Against Epilepsy because they really help give a visual impact as to what we're dealing with. And you see here that hypoxic ischemic encephalopathy is responsible for at least 35 to 45% of neonatal seizures. It is the largest player here when we look at etiologic factors. Dr. Carpenter spoke earlier about infarction and what that can do. And oftentimes the baby presents with focal status epilepticus, and we are then finding a perinatal acute ischemic stroke. There are genetic factors, there are infectious factors, there are brain malformations structurally when the brain is not formed well. Oftentimes the neurons where they are existing in the brain are not normal functioning neurons. And of course, there are the inborn errors of metabolism and the metabolic factors and the genetic factors. So let's talk a bit, just for a few moments, about neonatal seizure patterns. What are you likely to see when standing at the bedside of a neonate? And when is what you're seeing consistent with seizure? Apnea in isolation, more likely than not, is not going to be a seizure, but apnea with tonic stiffening of the body certainly could be a seizure. Focal clonic movements. By clonic, we mean repetitive, jerking, rhythmic movements. And by focal, we mean one isolated body part or one side of the body. It may involve just the upper extremity or just the lower extremity or both extremities, but on the same side of the body. Multifocal clonic movements can occur. Again, these babies are not well myelinated, but whatever is causing the seizure in any one part of the brain could be causing it in multiple parts of the brain. And therefore you could have multifocal clonic activity. We could see myoclonic jerks. Myoclonic jerks are rapid, lightning-like jerks that last only a millisecond or so. And the limbs move very quickly. They are often not repetitive and rhythmic the way clonic activity is. Some babies will present with paroxysmal laughing. It's quite rare. There can be tonic eye deviation. The eyes can move together upwards or towards one side. and that can be due to seizure activity in the brain. And then you could get tonic stiffening of the whole body. Neurologists use this word called semiology. Semiology means the study of signs. What are the signs that we see? And what is the pattern? So again, we talk in neonates about focal semiology, isolated body part, because of the unmyelinated or not fully myelinated brain, I should say. And clonic activity is by far and away more common than tonic activity. We can see multifocal activity, again, clonic more than tonic. The myoclonic events that occur could be focal, or they can, in some cases, be generalized. There are connecting pathways throughout the brain, but because they're not fully myelinated is why we often see focal activity. But there are connections, and you can see generalized myoclonic epilepsy or myoclonic activity. There are epileptic spasms that occur in neonates, typically flexion at the hip. They come in clusters, and they most often are seen upon arousal from sleep. Babies that are resting in a quietly alert state, rarely are you going to see an epileptic spasm. If you think of infantile spasms, that's something that has a very distinct presentation and is usually in the 3-month-old infant, not in the neonate. Autonomic signs are rarely seizures without other clinical motor manifestations that would look like a seizure to us, meaning isolated changes in heart rate, respirations, blood pressure, flushing of the face, salivation, or pupillary dilation. These are rarely in isolation going to be seizures. Now, having said that, if you have a baby that is on a paralytic infusion or is sedated for some reason and they're not moving much in general, then you need to be astute and aware of the fact that subtle changes in autonomic signs can in fact be a surrogate way to see that the baby's having a seizure, because if they're under paralytics, they're not, what if they're on the jet or an oscillator and they need to be kept very quiet and still. So autonomic signs can be, but are not alone, typically seizures. There are many movements that are seizure mimics. One, perhaps the most common, is jitteriness. The baby that's born perhaps going through neonatal abstinence syndrome, unfortunately, and we see the very jittery baby. But jitteriness is often something that will stop if the baby is held or if the limb is held. Opisthotonus, which is arching of the back, can be seen, and sometimes it happens in repetition. More often than not, opisthotonus would be instigated by some abnormality other than seizures, perhaps reflux and a pain and the response to the pain of reflux, but it's not seizure activity. Non-convulsive apnea, meaning apnea that's occurring completely in isolation without motor changes whatsoever, without blood pressure and heart rate changes. Non-convulsive apnea mimics seizures, and we're certainly happy to evaluate the baby who's having repetitive apneic spells for seizures with continuous EEG monitoring. But we need to understand that it often is not a seizure. There can be pathologic myoclonus. You can get myoclonus after a severe anoxic injury that is actually just the brain's minimal remaining activity, and it's not actually considered seizure. Benign nocturnal myoclonus can occur as well. And then there are normal neonatal movements. Babies move in all sorts of ways, and sometimes the best thing to do is just hold the baby, hold the limb, and see if it stops, because if it does, then that probably was not a seizure. One interesting phenomena are the neonatal motor automatisms. Those of us who are old enough remember that these used to be felt to represent subtle seizures in babies. And here I'm talking about oral, buccal, lingual movements, such as sucking movements. See a baby repetitively sucking on an ET tube, or even sucking on nothing, just sucking on the air. Chewing movements, swallowing movements, or repetitive tongue movements. There can be abnormal darting eye movements from side to side. Babies can do a movement that mimics the pedaling of a bicycle, where they can look like they're swimming. If they're lying on their back, they look like they're swimming and doing the backstroke, or they can have rotatory movements of their upper extremities. These are now better understood and felt to be brainstem release phenomena, but not seizures unless there's an EEG correlate. And again, we are always more than happy to be consulted for a baby that's having repetitive movements and may be sick for some other reason, which could be one of the etiologies that we often see for seizures, which we will talk about. And we're happy to come see the baby and put on a continuous EEG and determine if these movements are in fact seizures, because of course, if they are, we need to treat them. Here's a nice diagram from the International League Against Epilepsy, and we talk about the different seizure types, right? So there are predominantly focal seizures in neonates, rarely generalized. They can come with different epilepsy types, focal or generalized or combined. And there can be epilepsy syndromes. And there are multiple etiologies: genetic, structural, metabolic, immune, infectious, or unknown. So babies in the NICU often have comorbidities. It's not just their neurologic system that is sick. Another way to look at it, again, from the ILAE, is you have a critically ill baby or a clinical suspicion. So how are they presenting? They could have a non-seizure episode, meaning they have a movement without a video EEG correlate, or you put them on video EEG or AEEG, amplitude integrated EEG, and you see seizures with an EEG correlate. Now, if there's no clinical signs, let's say you have a baby who's sedated or paralyzed, but you have them on EEG and you see an EEG abnormality without clinical signs, that's an electrographic seizure or subclinical seizure. If there are clinical signs, then we can classify them. Are they motor? Are they non-motor? Last of this series of diagrams, let's look at this and go through it together. A baby at high risk for seizures or a baby with a clinical event. If an EEG is not available, we'll go down the right side of the slide. And is this being observed by experienced personnel? If an experienced observer sees focal clonic activity, even without an EEG, and it doesn't stop when the baby's limb is held, that's pretty good evidence, and it's probably a diagnosis of seizures. If you see abnormal movements, but they're not focal and clonic, even by an observer who is experienced, it's possible but not probable to be a seizure. And if there's been no observation by an experienced observer, you have simply insufficient evidence to make a diagnosis. Now, on the other side of the slide, we have our EEG modalities for making a diagnosis. We have the amplitude integrated EEG. We'll look here first. I'm trying to find my cursor for you. It's not working. Amplitude EEG. If there is a correlate on the amplitude EEG, that provides insufficient evidence to say that this was a seizure. But if there is a correlate on the amplitude integrated EEG and you have an abnormal movement and the baby's at risk, that's a probable diagnosis of seizure. But the gold standard is continuous video EEG monitoring. And if there's no correlation on that with the movement that you've observed, then the baby's not having seizures. But the gold standard is if there's an abnormality on that continuous EEG, then you are in fact dealing with seizures. So let's continue. And my slides won't advance. Hang on one second. My computer locked up. I'm so sorry. Can you hear me?
Yes.
All right, I have to get my computer to wake back up. It froze on this slide. I am so sorry. And I can't get it to end the show either. Hang on. Can you hear me? Can you hear me?
Yep, we can hear you.
All right, I'm going to share my screen. I'm so sorry for that.
No problem.
Find where the Zoom is. It's computer's misbehaving.
And you're sharing your screen so we can see your slides if you want
Can you
to.
see my slides? You can?
Yep.
All right, let me go right back to the that view. So sorry. Okay, so let's talk about some neonatal epilepsy syndromes. There is something called self-limited or benign neonatal epilepsy, often called fifth-day fits. The old terminology for seizures was fits, and they often occur in the fifth day of life. Some of these children will have a variation on the KCNQ2 gene, but most do not. Early myoclonic epilepsy is one. Early infantile epileptic encephalopathy, or EIEE, also known as Odo-Harris syndrome, often associated with structural abnormalities in the brain. Other genetic epilepsies are the KCNQ2 mutation and the SCN2A encephalopathy. The SCN2A is distinct from SCN1A, which is a voltage-gated sodium channelopathy. This is a different disorder and can lead to neonatal seizures. There are epilepsies that can be due to congenital brain malformations, lissencephaly, polymicrogyria, heterotopias, and others, and I'll show you examples in just a few moments. Other epilepsy syndromes, you can have GLUT1 deficiency, and we always need to be aware of the fact that if there is a disconnect between the amount of glucose in the serum and a lower glucose in the spinal fluid, that baby could have a GLUT1 deficiency, and it's very important to understand because there's, glucose is the main substrate for energy in the brain, and if you have a GLUT1 transporter deficiency and can't get glucose in the brain, you need to find another energy source, and in fact, it can be done. Biotinidase deficiency, pyridoxine-dependent epilepsy, molybdenum cofactor, I never say that right, deficiency, non-ketotic hyperglycemia, and all the other inborn errors of metabolism that can present with seizures. So the basic problem is we're diagnosing the seizure. What are we doing? What is our path towards diagnosis? How do we think about this? How might a neurologist think about this? Well, first and foremost, we always need to take a good history. The history is, as we tell the students and residents all the time, the single most important thing you can do. The physical and neurologic exam are, of course, important, but the history is really the gold standard. You've got to have a good history. One of the most important things to discern in taking the history was their neonatal encephalopathy or hypoxic ischemic injury, because as we saw in an earlier slide, that's going to be your leading etiologic factor for those 85% of children whose seizures are provoked by an identifiable etiology, right? There can be abnormalities on neuroimaging. There could have been a vascular event like a stroke or a hemorrhage, structural lesions like a cortical dysplasia or a schizencephaly with a cleft in the cortex, or there can be migrational defects where you have lissencephaly, polymicrogyria, or heterotopias. So before we move on to other diagnostic evaluations, let's talk about how we might image neonates. And Dr. Yazbek gave a great introduction to us and summary for us of the different imaging modalities. And I would just reiterate here that the ultrasound is the easiest to obtain, the fastest to obtain. You're not moving the baby out of the controlled environment of the NICU. The only downside really is its limited ability to see the fine detail that we would prefer to see on MRI or CAT scan. MRI versus CAT scan, we almost never do CAT scans. We need to avoid radiation. MRI routine versus ultrafast. Well, Dr. Groves was very kind this morning and gave us a wonderful lecture about many different things related to her role as a neurosurgeon with our neonates. And she spoke briefly about the ultrafast MRI, which has replaced the CT scan, especially when you need to look at ventricle size. But as her slide stated, and as I'll tell you here, a routine MRI with as many different sequences as possible and as the baby could tolerate, because remember, we have tiny babies in a very cold room, a routine MRI is going to give us much more information. You're not going to pick up gray matter heterotopias on an ultrafast MRI. You would see something such as lissencephaly on an ultrafast, but you might not pick up polymicrogyria and other things. MR spectroscopy, which of course is important, especially when we want to do metabolic imaging, where we actually get a graph rather than a photo. And what it's showing us are the different biochemical constituents of the brain cells that are in that area that's been imaged. And what we're looking for specifically here typically is a lactate peak, especially in a mitochondrial encephalopathy. So here's an example of polymicrogyria. You see where all these arrows are. There are way too many gyri, way too many. There's too many of them, and they're smaller than they should be. This does not look like the normal surface of the brain. Back here might look a little bit more normal, right? But up here, look at how many gyri there are. Those are abnormal neurons that are not going to function normally, and these children are at high risk for seizures. Lissencephaly, and here's a perfect example of a normal brain. You can see the size of the gyri and sulci here. And here is lissencephaly, or the flat surface of the brain. This is a pretty drastic version seen on MRI for comparison to the normal brain. And children with lissencephaly, you can have with lissencephaly on its own or associated with Miller-Dieker syndrome, where you'll have cardiac defects as well, and very classic facial appearance. Gray matter heterotopias. By heterotopias, we mean something that's in a spot where it doesn't belong. So on this MRI to the far left, the arrows are pointing to these lumps of gray. They have the same color and appearance of gray versus white as the cortex, right? Look at this nice area of gray cortex. Gray matter that does not belong lining the ventricles like this, nodular gray matter heterotopias. Here are some others. This is just a different sequence, but you can see them, and you can sort of see them here within a regular shape to the ventricular surface. And this is a picture that we would get when we did an MR spectroscopy. And this is showing us creatine peaks, choline peaks, and acetyl-aspartate, which is a marker for normal neurons. But unfortunately, you have a double peak, or the lactate doublet, which goes down rather than up. And so this is an MRS photograph taken from an area of brain where there was excessive lactate. What else do we need to do to make a diagnosis? Because remember, 85% of these babies are seizing because of something we can find if we do the right test. Well, is the baby hypoglycemic, hyponatremic, hypocalcemic, or hypomagnesemic? Because any one of those can lead to seizures in the neonate. And in fact, you're going to have a very hard time controlling those seizures with anticonvulsant therapy if you do not correct the biochemical defect. CNS infections are fraught with complications with seizures, bacterial infections, especially group B strep meningitis, viral infections such as herpes, and the torch constellation of infections. Drug withdrawal can give you neonatal abstinence syndrome, rarely seizures, but it can happen, or intoxication with certain drugs, especially if a mother was taking SSRIs or other medications or illicit drugs during pregnancy at the end and at term. Inborn errors of metabolism and genetic syndromes are also important to keep in mind, because we need to know what tests we're going to do, what blood tests are we going to collect. I don't have a picture here, but we often bag the baby for urine because we're doing serum amino and urine organic acids. And of course, the ultimate test here on the right side of the slide is the spinal tap to get the spinal fluid. That will tell you what is the glucose in the spinal fluid compared to serum, key to GLUT1 deficiency diagnosis. That will tell you if you have a CNS infection. And we can also look for glycine and other metabolites in spinal fluid. You can actually do amino acid surveys on spinal fluid as well. But of course, what it all comes down to is electrodiagnostic testing with electroencephalogram. And there are two types of electroencephalogram that we now have available to us in our University of Maryland NICU, right? We have the AEEG, which has been nicely integrated. It is amplitude integrated EEG, but it's been nicely integrated into our clinical armamentarium of diagnostic tools. We could do a routine EEG, and by that I mean just a 30-minute snap EEG. But the gold standard, as stated in that previous graph, is the continuous EEG with simultaneous video monitoring so that we can correlate the movements that are seen to what we see on the EEG. It is important to understand that the age of conception is correlated with what we see on EEG. There are different patterns that we see with eyes open or eyes closed. We can start to see continuous slow wave sleep in the older gestational age, and we start to see sleep spindles when you get over 44 weeks of age. There's a unique finding in infants at term called trace alternance, which is what this little cartoon is supposed to represent for you here. But the point is, EEGs change with time, with age of conception. So what's abnormal on one neonate may not be abnormal on another. Amplitude integrated EEG, what does it look like? Well, here it is. You see it uses far fewer electrodes, so it's much easier to connect to the baby. And it's collecting and storing data in time and giving us something that we can use basically for pattern recognition. Pattern recognition is what's important in AEEG. You're not looking at the raw EEG data, you're looking at it integrated over time. So here is what would be a normal raw EEG between two electrodes, and here is a normal looking AEEG. When you have discontinuity, where you have some activity and then some flatter activity and then a more activity over here, you may see some discontinuity in the pattern here on the AEEG. When you have burst suppression, where you have no activity, burst, no activity again, you can see these sharp areas here where there's a sharp stoppage along the bottom here and these lines of emptiness. So that's a way to look for burst suppression. Low voltage, you can see that the voltage here is much lower, and a flat or an active EEG will look something like this on AEEG. It's important, it's a useful tool, but it is often helpful to correlate the AEEG with, and this is a seizure, by the way, on an AEEG. This is the raw data. This is what the spike and slow wave looks like, spike and slow wave. And here you see on the AEEG, this change in the pattern, okay? This sudden change, these sudden upslopes, okay? But when you're doing a continuous EEG, you're putting on far more electrodes by number, and you're getting a much more complete look at the brain. And you can see here, each of these lines is connecting two electrodes. And this is what a normal neonatal EEG would look like. And here is a seizure coming from the right side of the brain on this neonatal EEG done on continuous EEG monitoring. And you can see spike, 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 spike. And the red lines are the right side and the blue lines are the left side of the brain on this particular picture. So how do we treat neonatal seizures? Because obviously we want them to stop. They are clearly pathologic. It's never normal for babies to seize in the NICU or anyone to seize anywhere. Treatment is based upon etiology whenever possible. So this is why it is so important when we know that 85%, the vast majority of these children have been provoked to have their seizure. Well, how do we treat them? For HIE babies, we're doing neuroprotection with cooling, but still up to 50% may have seizures. So you can't treat by cooling, but you can try to protect the brain from injury, and then you'd have to treat with anticonvulsant therapy. Infections need to be identified and treated. And again, remember that GBS is one of the leading causes of seizures in neonates. Correction of low glucose, sodium, calcium, and magnesium, as I stated earlier. And in the patient who has pyridoxine or pyridoxal 5-phosphate dependency, you treat appropriately with pyridoxine or pyridoxal 5-phosphate. This is actually, I don't know if it's going to show large enough for you to see on your laptops. But if you have neonatal seizures that are unresponsive to standard anti-epileptic drugs, that should raise your concern that there's a metabolic abnormality, whether it's glucose, sodium, calcium, magnesium. But what if it's pyridoxine? So you can give a pyridoxine trial and look for a clinical or EEG response. This is best done with EEG running at the same time. If there is a response to pyridoxine, then you're going to test for the biochemical abnormality, and you're going to be looking at either the urine alpha AASA or the plasma pipocolic acid. And if it's elevated, then you possibly have an antiquintin deficiency, and you can confirm that with genetic testing. If the urine tests as normal, they may have a different deficiency where you need pyridoxal 5-phosphate, and you can even give a leucovorin trial. But all of these are done with EEG running at the same time. How else do we treat neonatal seizures? For GLUT1 deficiency, as I mentioned earlier, glucose is the primary substrate for energy in the brain. In order to treat GLUT1 transporter deficiency, the brain will need an alternative source of energy, and the ketogenic diet can be the key here. Now, you could start with just a very high glucose infusion rate, very high GIR through your intravenous, but if you really want to treat that patient long-term, they need the ketogenic diet. Biotinidase deficiency can be treated by supplementing biotin. Molybdenum cofactor deficiency can be treated with cyclic hyranopterin monophosphate or with phosphatidopterin, which is a substrate replacement. And non-ketotic hyperglycemia, you can control the seizures with dextromethorphan, and you can address the hyperglycemia itself with sodium benzoate. But of course, there are anticonvulsants, right? While we're going to try to tailor our therapy to the specific etiology of the seizures, anticonvulsant therapy is often required. And I put phenobarbital in all capitals and all bold, not only because I happen to be perhaps the biggest fan in the building, but because this is the drug that's known to work best. Why? We know how much we give gives rise to what amount of a phenobarbital measurable drug level. We know that phenobarbital is very good at controlling seizures. We know that phenobarbital, when studied and published in 2020 by the NEOLEV-2 study, we know that phenobarb is far more efficacious than levetiracetam. And levetiracetam, if we're going to use it, Keppra by another name, we need to use appropriate dosing. We can't use little tiny baby doses, no pun intended, of Keppra and expect it to be effective. We need to be using 60 to 80 milligrams per kilogram to load, and then anywhere from 20 to 60, 20 to 40 at least milligrams per kilogram per dose of Keppra. But the other drug that works really well is fosphenytoin. And in fact, in combination, many of you have experienced either myself or Dr. Porter being big fans of the phenobarb and fosphenytoin combo, because when phenobarb's working but not fully, fosphenytoin can come in as the helper drug, and it can really work quite well. Using a benzo such as clonazepam can be helpful, but sometimes we have to go to continuous infusions. Lidocaine is not often used, but it has been reported, but a midazolam infusion can certainly help control seizures if they are, in fact, that refractory to other anticonvulsant therapy. We need to understand the duration of therapy here. Acute symptomatic seizures, seizures that often subside within several days, especially if you get the glucose or electrolyte abnormality fixed, if you have the meningitis under control, if the stroke is acute and now we're several days later, oftentimes you'll see on EEG that the seizures have stopped. And if in fact they've stopped, you can taper and discontinue your anticonvulsant therapy, possibly before discharge home. And if not, oftentimes we'll see the babies in the clinic, and after 30 days or 60 days of birth, when the baby's 1 or 2 months old, I'll repeat the EEG and then find that we can stop the anticonvulsant therapy. Because for older patients, that's certainly not the case. For older patients, we're looking for 24 months to be seizure-free before we're going to be taking you off your anticonvulsants for many of the epilepsies. There are patients, however, who do have epileptic syndromes that require longer duration of treatment, unfortunately, But it is very gratifying when a baby's seizures stop and are controlled and the etiology has been corrected and we can get the babies off anticonvulsants. What is it that leads to the injury in the brain? Well, remember we spoke earlier about reduced dendrites and reduced synapses in the brain. Well, consistent, persistent seizures can lead to reduced dendritic spine density, and that's seen in the hippocampal pyramidal neurons. The hippocampus is the area of the brain that is fraught for seizures, and you can see alterations in the cellular structure of the hippocampus. Also, you can see altered hippocampal plasticity, and you can see altered neuronal circuitry and decreased neurogenesis. And in children with hypoxic ischemic encephalopathy and seizures, oftentimes these children will have 30 points lower on their full-scale IQ than that which would have been predicted. It's an interesting corollary to children who, say, get radiation for a brain tumor at 5 years of age, and then several years later, they've also lost full-scale IQ points. For the neonates, what we're looking at is loss of IQ points from that which would have been predicted by an average IQ of their parents. How do we predict the outcome for these patients? Well, the seizure burden and status epilepticus. If you have difficult to control seizures or you're in status, you're going to have less good of an outcome. If the neurologic exam is abnormal and the child's encephalopathic at the time their seizures are diagnosed, if multiple medications are required for seizure control, that is a foreshadowing of a poor outcome. If there's a neuroimaging abnormality, also gestational age and birth weight, the younger, smaller, and preterm babies are at risk for long-term neurologic difficulties. And the EEG findings, if you have lots of ictal spread from one hemisphere to another and a very burdensome EEG, in addition to the clinical burden of seizures, you can expect a poor neurologic outcome. So what then is the prognosis for our babies who are having seizures? Well, unfortunately, there is a risk of early death, especially in babies whose seizures are associated with severe HIE, with a high seizure burden, or if they're premature. And that can be seen in as many as 15 to 35% of these babies. Some other form of neurologic impairment and cerebral palsy can be seen in 25 to 40% of babies. Remember, some of these babies are seizing because of stroke, and Dr. Carpenter mentioned earlier how we see cerebral palsy after stroke in the neonatal period. Developmental delays, whether they be global or isolated to speech or other intellectual executive functioning and ADHD and things of that nature, in as many as 40 to 50% of our babies. Post-neonatal epilepsy, fortunately, only occurs in about 20 to 30% of the newborns that we're treating. And there are a fair number of patients who will not have epilepsy at all with no neurologic abnormalities in as many as 35% of our patients, which is really quite nice. And I'll end with that and remind everybody that on a really nice, beautiful, sunny day with partially cloudy skies in Baltimore, our institution looks quite handsome. And there's nothing like a sunset down at the Inner Harbor, if you ask me. And I will take your questions. Sorry for the glitch in the middle.
No, thank you so much, Dr. Thompson, for that fantastic review in neonatal seizure. I think the data is still about what to do with this subclinical seizures on AEG in the very premature infants. That's still debatable. And I wanted to get your opinion on that. And certainly we know that the higher risk of these babies is quite early.
Yes.
I mean, us all having a seizure. However, we are not monitoring these babies routinely. So and I think there is a huge need for that.
Yeah, I would agree. I think we need to be monitoring more and more and more. We can certainly start with AEEG, but if you use AEEG and you start anticonvulsant therapy based on that, and you're not seeing a response, we really ought to put the baby on continuous EEG with video and see. And even if the seizures are subclinical, we need to try to get control. Because we know that uncontrolled seizures can be damaging to the premature brain, or to the immature brain, I should say, in the newborn. I think more, if we had more machines, we'd be monitoring more and more and more. I would have a very, very quick trigger to say, yes, you're calling, you're even just the slightest bit concerned, let's monitor this baby. We can start with AEEG, we can always add continuous EEG afterwards. But I think we should be monitoring as many babies as possible. Not every single baby needs to be monitored, but babies with significant IVH, babies who've had a rough time with an infection, babies who've had to be resuscitated for whatever reason after septic shock or neck or something. You know, the more monitoring we do, the more seizures we're going to find and treat and make these babies' outcomes better.
The question then comes, for how long do you monitor these babies?
How long? I would monitor them until we see the seizures controlled, right? Now, once you have the seizures controlled, then you have to do some expectation monitoring of your own and expectation counseling with the family, because some babies will still have an occasional seizure once a day, once every 3 days, once a week. If they have a severe structural abnormality in the brain or a severe IVH or a severe HIE, you may not get 100% seizure control. So, and we know that the longer we keep electrodes on, the greater the risk for skin breakdown, and we don't want to give the baby with skin breakdown a risk for an infection.
Sure, but I was more referring to, say, severe IVHs in the very early premature infants, and as they develop post-hemorrhagic hydrocephalus, we're talking about these babies spending months in the NICU.
Right, and we're not going to monitor them the entire time they're there. We're just
unfortunately, though, I think that is the future, and it will be interesting to do that, like we do the heart lately. But anyway, that will be for the future.
And well, it certainly would be, it certainly could be done longer term with AEEG, right? Because you have fewer electrodes, less skin breakdown. You know, if we had 25 AEG machines, I think we'd all be thrilled, you know, to have the number that we have is a good start, but having more would certainly be better, especially a very premature baby who's had an IVH or something else, and you want to monitor them because you don't want to miss the seizures. You know, I totally agree with you.
Dr. Thompson, for the families who are, I would say, under-resourced, once they go home, I mean, I imagine that plays a large role in the outcomes of these children. What is your clinic seen of these kids and their outcomes, and what's been contributing to their success in terms of follow-up and, you know, adherence to medication and whatnot?
I think what starts to build success is establishing a rapport with the family while we're here. And now there are more neurologists here now, you should know. So we rotate every week instead of just seeing me and getting tired of my face all the time. But whomever is there making rounds and is on service at the time of discharge, even if the baby has done well and we've signed off, we ought to come back in and educate that family before discharge. Like, we should be told, hey, this baby's going home, you know, they're stable neurologically, but do you want to meet with them? Educate the parents, make sure they understand how they're giving their medication, make sure we know we have the medication going to the right pharmacy, making sure that they know they need to come not just to the NICU follow-up clinic, but also to neurology, giving them the resources to call us because our nurses can do education at any time. And we'd like to make sure that every family has my portfolio when they leave, so they can message directly to one of the neurologists that they've seen while they were in the NICU so that we can help them. I think the stronger the communication and the stronger the connection we can make with the family on a human level, the more humanistic the approach and the more focused we are on education, the greater the success.
Thank you.
Thanks. And I would also say that I think one of the really nice things is the fact that for a lot of our patients that we're seeing in our downtown location, rather than out at Lutherville or Hanover or Upper Chesapeake, we're often seeing them in specialty clinic, the one floor above where they just spent several months of their newborn life. And the developmental pediatricians are here at the same time. The NICU follow-up is often here at the same time. So we can collaborate and we can talk to each other. And I think that creates additional levels of safety and safety nets, if you will, for the families. Thank you, everybody, for listening.
Thanks, Dr. Thompson. Just another quick question. When you're following these patients out in the outpatient world and you're deciding either coming off therapy or continuing to stay off therapy, when you're doing your EEGs outpatient, how long are you keeping those patients on EEG to kind of determine they don't need meds anymore?
So that's an interesting question. We typically do a routine 30-minute EEG, right? They come in, they go to the EEG lab, 30 minutes to put the electrodes on, run it for 30 minutes, 30 minutes to take it off. We can ask them to run an hour, but I will tell you, if we are concerned, we can, and especially if it was a refractory patient, we can do a 48-hour EEG at home. We don't have to admit them, but we can get long-term monitoring, even up to 72 or 96 hours. We can do it at home if we feel that we need more data. Also, for babies who were controlled with Keppra, if that was the drug that was used, I'm often going to repeat the EEG once they're fully tapered off, because Keppra can notoriously make the EEG look better than it truly is. So if I get a good EEG at day 30 post-discharge, right, and I want to taper them off Keppra, they come off Keppra over several weeks, I may then repeat the EEG and make sure that we weren't fooled by the Keppra, because I don't want to leave them home with subclinical seizures.
Thank you. Does anyone else have any questions for Dr. Thompson?
I don't see any in the chat. Great, thank you.
Sounds good. With that, we will roll into our next presentation. Next up, we have Dr. Erdemir, who will be speaking on IVH. Dr. Erdemir was born and raised in Turkey. After finishing medical school in Turkey, she pursued a pediatric residency at the State University of New York. She finished her pediatric neurology and epilepsy fellowship at Cleveland Clinic. She joined us here at University of Maryland as an assistant professor last summer. I'm sure some of you have seen her in the unit. With that, I will let you go ahead and take it away.
Hello, everyone. Do you see my screen well?
Yes.
Okay. So yes, we are going to talk about intraventricular hemorrhage today and the recent innovations about it. It is going to be a quick review. We are not going to go into details, but I hope we will cover the basics. So we will talk about epidemiology and pathophysiology, risk factors, biomarkers, and presentation, diagnosis, and outcomes. And at the end, we will also talk about management. As we all know, IVH is very common. It is the most commonly diagnosed brain disorder in preterm infants. And the biggest risk factor is prematurity. It tends to occur in the sickest preterm infants, and we basically diagnose it with cranial ultrasound. We are going to talk about diagnosis later, but this is the most common way to diagnose intraventricular hemorrhage. Worldwide incidence is 20 to 40% of all preterm infants, but as you can see, this is a big range, and it changes from country to country. It changes from even NICU to NICU in same country. But in United States, we know that annually there are like 3,600 new cases of people affected by intellectual disability due to IVH. So it is a big burden, and it also causes a lot of financial burden too. And the combined lifetime care cost for these children is more than $3.6 billion. There was a project between 2003 and 2007 in NIH. They looked at the outcomes of 9,500 extremely premature babies. They were all less than 28 weekers, and they weighted less than 1,500 grams. And overall, 16% had severe IVH, and severe IVH in this study, it was grade 4 IVH. And grade 1 IVH, they looked at the different gestational age and association, and they didn't find an association between decreased gestational age and grade 1. It was constant from 22 to 28 weeks. But grade 2, 3, and 4, IVH increased when gestational age decreased. And grade 4 was seen like 30% of all 22 weekers, but only 3% of 28 weekers. So even like 1 week makes a huge difference. What about in-term infants? I will talk about mostly preterm infants, but I wanted to give a little bit information about terms, and it is pretty rare. Incidence of all intracranial hemorrhages, not IVH, all intracranial hemorrhages, which includes subdurals, epidurals, is 0.27 to 0.49 per 1,000 live births, and severe IVH is even less frequent. What is the pathophysiology? So you see here, this is the basic anatomy I can find. You see here with green germinal matrix, and all the IVH arise from these fragile vessels of germinal matrix, and rapid hemodynamic fluctuations usually cause that bleeding. Ischemia and reperfusion events will stress that germinal matrix. And there are 3 main reasons. It might be intravascular factors, vascular factors, and extravascular factors. Intravascular factors, the preterm babies don't have a good cerebral autoregulatory mechanism. It is still immature, and abrupt alteration of cerebral blood flow and pressures can cause bleeding just because they cannot regulate the cerebral blood flow. Vascular factors, as I said, germinal matrix vessels are very vulnerable, and if they are underdeveloped in preterm babies, they are even more vulnerable to hypoxia and reperfusion injury. There are also some extravascular factors like systemic reasons, and most frequent ones are metabolic derangements and underdeveloped cardiopulmonary system. Hypotension plays a big role here, and there are studies showing that infants less than 1 kilo have 24 to 40% of these infants have hypotension, and intubation with positive pressure ventilation increases the central venous pressure. And if you increase the central venous pressure, and if the baby is having also episodes of hypotension, this can lead poor cerebral perfusion. There is another study looked at the hypotensive babies and normotensive babies at the same weight and same gestational age, and they found that hypotension was associated with IVH as well as other problems like PVL and long-term neurological disabilities. So we need to keep their blood pressure stable and up. This is a big slide, and it shows most of the factors. As you see, hypotension is the most important in cardiorespiratory system, and low cardiac output, PDA, increased central venous pressure, hypoperfusion and reperfusion, hypercapnia. Metabolic-wise, hypoglycemia, hypernatremia important, and anemia, thrombocytopenia. Thrombocytopenia is even important for term babies. And immunologic-wise, infections, sepsis, chorioamnionitis, immature immune response, they all contribute to IVH. And again, there is immature cerebral reactivity. So if there's a hypercapnia, there's a vasodilation. And if there's a hypoxia, there's a vasodilation. And there are a lot of blood going to the brain, and it will cause bleeding. These are this is the summary of all the risk factors. There is one important thing here I will mention, but again, abrupt changes are bad. Rapid changes in CO2 pressure is bad. Rapid changes in aortic pressure, rapid infusion of volume expander, and excessive increase in vasopressor infusion. These are all big risk factors. But you see here, noxious procedures are also mentioned as a risk factor. Suctioning, peripheral IV insertion, central line insertion, loud noises, aggressive handling. These are all causing some risk factors, and there are studies showing this can really be affecting the baby's future development. And again, large PDA is a big risk factor. And if the patient has pneumothorax or excessive ventilator pressures, the risk factor for IVH is also again increased. And delivery mode, this was hypothesized before, and people thought that vaginal delivery is too risky to have preterm babies because it will compress the skull and it can cause the IVH. If you think about like this, it makes sense, but studies didn't show it. There was no difference between vaginal and C-section deliveries, and IVH rates were pretty similar. They also checked delayed cord clamping. Several studies show that delayed cord clamping associated with reduction in IVH, but the most recent large clinical trial didn't show any association. So what you do in delivery, mode of delivery, and delayed cord clamping actually didn't matter. What about term infants? So term infants are completely different, and their reasons to have IVH is completely different. And trauma during delivery is the biggest risk factor, but they can have HIE, which can cause IVH also. And coagulation and platelet abnormalities are common cause for IVH. Hypothermia can cause it, especially during ECMO. If there's a sign of venous thrombosis, it may eventually cause IVH. And there are some rare causes. There are some gene mutations of collagen genes. There are some coagulation, genetic coagulation problems, or rupture of vascular malformation. They can all cause IVH, but we are gonna stick on preterm babies. Researchers try to find a biomarker to predict which preterm infants are most at risk for IVH. Is it going to change anything if we know that the patient has increased risk for IVH? We are not sure, but they checked a couple of things, and they thought if there is some oxidative stress biomarkers in cord blood, this can be associated with IVH. And they were right. They looked at the non-protein bound iron, total hydroperoxide, advanced oxidation protein product levels, and they were all high in the patients with risk of free radical diseases, and they caused IVH. Another study showed a direct association between IVH and erythropoietin levels. And there is another recent study showed that interleukin 1P and interleukin 18 were found in preterm infants with post-hemorrhagic hydrocephalus compared with the levels in controls. Additional studies are needed. These are all like small studies, but it looks like there might be some biomarkers can help us to predict risk for IVH. Timing of IVH, it may begin in utero, but it is usually after birth. There's a meta-analysis from 2000 which showed they looked at the low birth infants, less than 1.5 kilo infants, and half of the IVH cases occurred within the 6 hours of life, and only 1/3 of the cases occurred after 24 hours. So first 6 hours of life is very important. But it might be small at first, and then it can progress to larger. And if this is the case, it is important to notice differences on exam. So nurses are very important to catch the presentation. So how can it present? There are three types. It might present as very catastrophic or saltatory, or it doesn't show any signs. It might be clinically silent. Catastrophic means it progresses over minutes to hours. And usually, although it looks bad and it is catastrophic, usually neurosurgery doesn't do anything because they think it will cause more harm. And it presents as stupor or coma, irregular respirations, hypoventilation, apnea, posturing, seizures, especially tonic seizures, flaccid weakness, and cranial nerve abnormalities, including fixed pupils. There is another presentation, which is more common, this saltatory, and it presents hours to days. And the most important thing is decreased alertness and activity. And it might be hard to detect in newborns because they sleep a lot. And if you don't think about it, you may not notice it. That's why nursing team is very, very important. And hypotonia, tight popliteal angle, abnormal eye movement, and respiratory difficulties are the other signs. And what silent presentation can be expected if we see some unexplained decline in the hematocrit. And if we see dropping hematocrit on CBC, we should think about IVH. Diagnosis, as you all know, we do ultrasounds, and ultrasounds usually show it. But subtle abnormalities can be difficult to detect with ultrasound, and MRI, there is a study show that MRI detected IVH plus cerebellar hemorrhage in 10% of all preterm infants. So if the patient has a cerebellar hemorrhage with ultrasound, you usually miss most of it. Ultrasound detected only 23% of the cerebellar hemorrhage. Ultrasound shows IVH very well, intraventricular hemorrhage, but if it is posterior fossa, if it is in cerebellum, it's not a great tool. So for all the IVH patients diagnosed with ultrasound, eventually you'll need the MRI. And why it is important to see cerebellar hemorrhage? Because children with cerebellar hemorrhage had 5-fold increased risk of abnormal findings on neuro exam in future, and neurological prognosis is different, and MRI gives a better prognosis to us. But of course, ultrasound is the very easy and good tool to have at first. And I am sure everyone knows this papille grading. There are 4 grades, and especially right now we don't say grade 4, we say periventricular hemorrhagic infarction instead of grade 4. And grade 1 is restricted to the subependymal parenchyma, and it is less than 10% of the ventricle. It is only around the germinal matrix. And grade 2 extend into ventricle, but it doesn't expand or occupy more than 50% of the ventricle. And grade 3 involves more than 50% of the ventricle. And grade 4, and the new name is PVHI, is extensive. It goes to it has parenchymal involvement. And you can see the real brain here, and you can see the IVH here, but it also includes the parenchyma, and it causes the hemorrhagic infarction, this is the grade 4. And coronal plate, this is the ultrasound, and coronal plate is the best for detection of the IVH, and sagittal plate best for determining the extent, because you can see from front to back. And here in D, you see a small grade 1, you see the hyperechogenicity here. And in E and F, you see grade 2, it is like, actually it is around 50%, not more than 50%, but it's around 50% of the ventricle. You see it is like a bright, blood looks bright in the ultrasound. And in G, you see most of the ventricle is filled with blood, so it is grade 3. And in H and I, we see grade 4 with, you see the parenchyma is involved, and it is not only in ventricle, it goes to the parenchyma. Outcomes are different. Grade 1 doesn't cause any additional problem. Their developmental disabilities are similar with premature infants without IVH. So I shouldn't say we should ignore grade 1, but I tend to ignore grade 1 hemorrhages because it doesn't cause a lot of problems. But moderate ones, grade 2 and 3, cause neurodevelopmental disability in 40% of the patients, and mortality is 10%, and they can go to progressive hydrocephalus in 20%. And severe IVH, almost all the time, 80% cause major neurodevelopmental disability, and mortality rates are really high, 50 to 60%. And hydrocephalus is very common. And post-hemorrhagic hydrocephalus, it is a dilation of the ventricles after IVH, and that periventricular white matter injured, so it gets dilated. And also there's a inhibition of CSF flow because of the hemorrhage, so it contributes too. There are two types, acute and chronic. Acute dilation happens very frequently, like up to 50% of the infants with IVH, but it generally resolves. And the other 50% of the severe cases will result chronic progressive ventricular dilation. And pathophysiology, again, this blood impaired CSF resorption due to it causes fibrosis of arachnoid granulations, so CSF cannot be resorpted, and it causes meningeal fibrosis and subependymal gliosis. And arachnoid granulations are not yet mature in preterm infants, so they cannot resorb it. And then CSF accumulates, and that causes increased ICP, and it causes white matter damage, and it causes hydrocephalus. Presentation is similar to symptomatic hydrocephalus in term babies. You see increased head circumference and fontanelle full, sutures might be splaying, and that progressive splaying of the sagittal suture is the most reliable indication of increased pressure because it is the most sensitive test. And other signs of increased ICP is apnea, bradycardia, lethargy, again, decreased activity, but these are all non-specific. So head circumference needs to be checked every day, sometimes twice a day for all the IVH babies. Medical management. So there are a couple of options. Vitamin K was promoted as effective prevention in past. And there is a study showed that it decreased IVH rates by 20%. But the recent meta-analysis didn't show statistically significant effect. But we give vitamin K to all the newborns to minimize vitamin K deficient bleeding, although it looks like it doesn't affect the IVH occurrence. Sorry. The other thing was hypothesized before is the coagulation factors. In 1973, there is a trial showed prophylactic treatment, like with fresh plasma, reduced IVH incidence from 33% to 13%, which is very significant. But subsequent studies couldn't replicate it, and currently, today, it is not recommended. Glucocorticoids, In 1972, there's this landmark study showed that it decreased the respiratory distress syndrome if given antenatally, and because of that, they checked the severity of the hyaline membrane disease and association with glucocorticoids, and they found that there is a decreased risk of hyaline membrane disease and decreased risk of IVH. So there was a meta-analysis in 2017, and it showed a significant decrease in IVH. So, and we use it commonly. You use it commonly in prenatal in mothers, and because of that, NIH report says that severe IVH rates dropped from 19 to 16% in a 10-year span. So it may not look like a big drop, but I think it is significant drop because of glucocorticoids. Angiogenic inhibitors. So these are potential in IVH treatment by stabilizing the germinal matrix vasculature. And there is a study, they looked at that COX-2 inhibitor, celecoxib, and also this vascular endothelial growth factor R2 inhibitor, ZD6474. They reduced the incidence and severity of germinal matrix hemorrhage in preterm infants, but this is only one study, and it needs to be replicated, and we need a bigger study, but it is promising. What about surgical management? So I'm not a surgeon, so I maybe shouldn't talk a lot about this, but I will give you a quick review. Lumbar puncture emerged as initial treatment at the beginning of 1900s, and in 1940s they reported symptomatic improvement with some 15-20 milliliter CSF drainage. Today it is still used, but serial of lumbar punctures for IVH is not recommended routinely, and it has only level 1 evidence. What else we do? There is no consensus on optimal surgical management. If post-hemorrhagic hydrocephalus progresses, patients may need temporary or permanent CSF diversion. And if the patient requires some intervention, 35% to 60% will eventually receive ventricular peritoneal shunt, which is a permanent therapy. But this permanent diversion has some risks too, and it can cause a mental blockage. We can see fibrous sheath groove, infections are common, and the need for shunt revisions are up to 84%. And especially in preterm infants, they have higher risk for postoperative infections. And if the patient has a meningitis associated with this ventricular shunt, there's a significant decline in performance at 2 years of age. So that's why we are not jumping to permanent diversion right away, and it is recommended that insert a temporary shunt first. If you think that there is signs of elevated ICP, you do serial imaging studies, and if it is getting worse, some people do routine serial LPs, but it is not recommended. And then we place a temporary shunt, which is a reservoir or VSG. So with placing the temporary shunt, we delay the insertion of permanent shunt, and when the infant is older, they better tolerate it. So we just delay the permanent shunt with the temporary one. There are other surgical management options too. One was streptokinase. This was in 1990s. It was hypothesized that if we lyse that blood clots, then the ventricles will be open and the hydrocephalus will get better. It makes sense, but in controlled clinical trials, it failed to prevent shunt dependency or death. So it is not currently used and it's not currently recommended. This is another thing, drift therapy, which means drainage, irrigation, and fibrinolytic therapy. So they drain the CSF, they do some irrigation, and they put some fibrinolytic in the ventricles to open them. So it was again popular in the 2000s, and there is one study showed it reduced mortality, it reduced disability rates, and it was really promising. But it was in phase 1 trial, and it was only with 24 patients. Later, we have a randomized study which failed to reduce mortality, and actually it caused more harm. It showed secondary IVH was major complication, and it was contracting with potential therapeutic effects. There are other recent innovations too. These are GSK3B is a integral intracellular kinase, and they think that it impairs neurogenesis in IVH. If you give the inhibitors of GSK3B, you may augment the neurogenesis. So that is the hypothesis, and there are rabbit studies right now, and it is very promising. And there are also some mesenchymal stem cell studies. There is one phase 1 clinical trial in humans, and it showed that it is both safe and feasible, but we don't have the actual effects phase 2 study. So these are the time course of the treatment and management of IVH. Again, shunts, punctures, vitamin K, corticosteroids, and now we are here with that GSK3B inhibitors. Maybe in 10 years, we will be using them regularly. Again, this is another picture. So what else we can do? We should try to prevent preterm birth. We should promote utero transport, promote a no stressful intrapartum course, efficient resuscitation, cluster care activities, appropriate handling, minimize noxious stimuli. This part is, I think it is very important. That part is very important because it can easily be done. And we should avoid events associated with wide swings in arterial and venous pressures. We should prevent blood pressure swings and overventilation. We should try non-invasive monitoring devices if we can, and we should maintain normal pH, correct abnormal clothing, be alert to signs of hemorrhage, treat hypotension, use indomethacin, optimize respiratory management, sodium bicarbonate. It also, I think I didn't show that study, but there are studies showing that it may increase the risk of IVH also. So that is the other thing was hypothesized when in 1980s. They thought if we keep the head in neutral position, it should decrease the risk of IVH. Infants less than 32 weeks, they were positioned in neutral midline position, and bed was tilted upward 72 hours. And they tried to reduce alterations in cerebral blood flow associated with turning of head, but most recent review didn't show enough data. So this is not evidence-based, I should say. I think these are all I have, and I will stop here talking. I can take your questions.
Hi, thank you for that great overview. This was a question I had hoped to ask Dr. Groves, but I didn't get a chance to. And I think one of the issues we see at the bedside as neonatologists is maybe a disconnect between our.
I cannot hear.
Fran, we're having a little trouble hearing your question.
Okay.
Is this better?
Much
Yeah.
better.
Yes.
Okay, sorry. I was saying that one of the issues that I think we have as neonatologists, practitioners at the bedside, is there's like a disconnect between our notion of what constitutes hydrocephalus that is symptomatic versus what surgeons might be defining as symptomatic. And I think when we're communicating with families, we are there daily, we're examining daily. And, as much as the Fontenelle supposed to be like this objective measure, it's often subjective. I mean, are there any tools under development that will help more like better standardize our definitions? Because there have been times when I've used the term hydrocephalus based on radiographic imaging in my exam, but then the neurosurgeon is not calling it that. So look, it can be very confusing, and it can be hard for us to be on the same page with families when it comes to, yeah.
Yeah, I agree. There are two measures on the ultrasound, AWI and V.
The ventricular index.
Yes.
Yeah.
So these two, the radiologists use them a lot. I am not sure if the neurosurgeons use them as a prognostic factor or as when they make a decision. I'm not sure if they use it. We also don't use them consistently. It might be nice to actually look at it and maybe establish a common practice, because if we use these terms, it would be like everyone will be on the same page. You are right. It is tough usually because the clinical assessment changes even in hours, and the NICU team knows the patient very well, but the consulting teams don't examine the patients that frequently. So usually we are based on the clinical, we go with the head circumference and the radiology reports. I usually don't measure myself, but I think it is worth to look at it, and maybe we can use that tools to make it standardized. And there are some studies looking at that thresholds to do surgery. They look like how big should be the ventricle to do the surgery, and they actually couldn't find any difference between 97% of the so 97% was their cutoff. 97% deviation, standard deviation was their cutoff, but they didn't think that it was effective. So they think the clinical assessment is the most important thing here. And I think the surgeons are going with the clinical assessment too, based on the patient's symptoms and signs.
Yeah. Because I think that the Elvis studies, when I think they use 90th percentile of the ventricular index, but all of those tools are used in the studies, but we don't use them at the bedside. So I think it'd be helpful if we did.
Yes, you're right.
Right. I think you bring an interesting an interesting conversation and something that we can probably follow up back with Dr. Groves. But Dr. Erdemir, thank you so much for your presentation. I also wanted to say, in the past, we had asked this question to the neurology team, Dr. Thompson at that time. Now that we have more, thankfully, now very glad that there are many more now, has been when to start a neurology follow-up with these babies with IVHs. We certainly at some point, if the babies are developing post-hemorrhagic hydrocephalus or the more severe forms, tend to get you involved when they have seizures or but not early or in prevention measurements. So it's, what is your thought from that?
Do you mean inpatient? Like inpatient?
Yes, yes.
How early? I guess as soon as you diagnose the patient, I am thinking like, do we need to be involved earlier for all the patients with the concern of increased ICP or IVH? Probably yes, but do we make a big difference if we are involved early? I don't really think so. So I think as soon as you got the ultrasound and you saw them, you saw the hemorrhage, we should be involved. But I don't think it would be helpful if we are involved earlier than that, because there is no real tool to prevent it other than making standard care. And after the discharge, we like to see them in 2-3 weeks as soon as possible to give a global idea about how the patient is doing, and then we follow them regularly regarding their development.
At this moment, I don't think that we have routinely neurology consultation on babies with IVH only.
You don't?
I think we should.
Or
But I think it's something that we have discussed before, Steve. Do you remember? And I think it is important.
Yeah, I think we should. Now that we have a real team and it's a group of us, I think it would be great. You know, because they're going to end up needing to see us more than likely at some point outpatient, and to not know them inpatient is sometimes not good for the family, and it just makes for more comprehensive care.
Yes.
And maybe not for grade ones, because
Right.
it affects neurodevelopmental.
Certainly for the 3s and 4s.
But
right?
Yeah, 2, 3, 4s. Yes.
Yes, I agree. But know that at this moment, that's not the routine care.
Okay. No. Okay.
Yes, thank you, Dr. Erdemir.
Thank you.
Thanks so much for that presentation. And we will then roll into our next presentation, which will be done by our own Dr. Schofield, who will be going over as Golden Hour, Golden Week, and DR management. So I will let you go ahead, Dr. Schofield.
Thank you, Natalie. So I did limit it to just Golden Hour. The Golden Week was hard to do in 30 minutes, but I can touch on it a little bit. I did take those slides out though, so my apologies. But hang on 1 second and let me share my screen. Oh no, oh no. You think I would be used to Zoom by now since I've been doing it all day for interviews, but here we go. All right. So I just want to talk about a topic that's really relevant to sort of neurocare of the ELBW infant. So obviously it's relatable here, but it's important for all babies who get admitted to the NICU, and even those who don't. That first hour is really crucial to kind of, you know, being the window to the rest of their lives, because if they don't get through it, then, well, they don't have the rest of their lives. So I'm just going to talk about the golden hour specifically as it relates to the ELBW infant and neurologic implications of things that can go wrong in it. So why should we have a golden hour is something that a lot of people ask. And it's really because of what I said previously, that the physiologic transition from intra to extrauterine life is really one of the most critical time periods where a lot of things can go wrong. So the term golden hour was borrowed from trauma, and it was actually sort of developed right here at Maryland in shock trauma, and also cardiovascular or stroke, heart attack medicine. Other institutions that have implemented golden hours or golden weeks. Golden week is a more sort of in-depth extension of the golden hour that goes obviously for the first week of an ELBW's life, but just by implementing golden hour protocols in other facilities, they have improved time to surfactant administration, early administration of dextrose and amino acids, which has benefits. They've improved normothermia at admission, which is something that we're really trying to focus on here at Maryland. The odds of developing chronic lung disease were improved, and the odds of developing ROP were also improved. So the trauma golden hour, just to put it sort of in table format so everybody can see, and if anybody has questions, please feel free to just interrupt. I don't know how to use the hand raise feature, so just talk. So the trauma golden hour starts at the time of the injury. So whether that's a car accident, a gunshot wound, they want the on-scene response and assessment to be done by 10 minutes. In the next 10 minutes or 20 minutes, they want on-scene emergency care to be provided and the patient to be stable enough to be extricated from, if it's a car wreck, a plane crash, I don't know many people surviving those, but a gunshot wound, wherever they are, and then 10 minutes to transport to the facility. So really in the emergency department, that part of it is only 10 minutes. So it's 50 minutes. They get to the emergency room by 50 minutes from the injury. And then in 10 minutes, they're stabilized in the emergency room in order to go to surgical intervention by 60 minutes. So that's the trauma golden hour. And I will go through components of the neonatal golden hour and then show you a table that sort of summarizes our response times. So really, the golden hour starts well before the hour. It is the golden hour for the infant, but it takes a lot of planning on our part with nursing, respiratory therapy, OB, everybody that's involved with delivery. So if it's possible, if there's time, if it's not, you know, a 24-weeker rolling in off the street with placental eruption, we love to do antenatal counseling with the mom just to set the expectation, the survival rates. If the infant is peri-viable, so really less than 24 weeks here, we like to have a discussion about the extent of resuscitation that's likely to be helpful in these infants and when we would stop, and really how we wouldn't go sort of full court press as we would in a full-term baby. We like to verify the gestational age. So sometimes if the OBs can get a quick bedside ultrasound, do a history with mom, if it's somebody who they're not familiar with, it really helps us prepare if we have a better idea of the range of gestational ages that the baby could be. Very helpful also to know the estimated fetal weight. Resuscitating a 310-gram baby is a lot different than resuscitating a 600-gram baby. Knowing whether the baby has had antenatal steroids really makes a difference in the resuscitation. You obviously prepare for it the same way, but the outcomes are very different if the baby has had antenatal steroids. So just verifying that they have, and if there's time, giving it to them before delivery. Currently, it's recommended for infants less than 34 weeks, between 24 and 34 weeks, or less than 34 weeks. But here, based on discussions with our OB colleagues, we are offering steroids at 22 weeks and 5 days with the plan to resuscitate at 23 weeks if the baby is steroid mature. Obviously, there are other sort of exceptions to this on a case-by-case basis, but that's sort of the framework that we operate under now. We also like to know from our OB colleagues any pregnancy complications. Did the mom have chronic hypertension? Did she have repeated infections, UTIs? Was the baby showing signs of fetal growth restriction? And then comorbid diagnoses. So all of these things influence how we resuscitate a baby and what we can expect during the resuscitation. So very important to know if the mom is diagnosed with chorioamnionitis, the baby has any suspected genetic diagnoses, and certainly cardiac defects, because it's very different to resuscitate a normal 24-weeker who's well grown versus a 24-weeker who is suspected to have something like hypoplastic heart, hypoplastic left heart. So before the golden hour starts, which is when the baby's born, the delivery team and the admitting nurse should be briefed, go over everything that you've learned, what you're expecting, what kind of baby you're kind of expecting to deliver to the NICU after the resuscitation. You want to have a pre-warmed isolette that's ready in the delivery room. It's really helpful to have common medications at the bedside. And I know that here at Maryland, we are working with pharmacy, with nursing management, to try to stock some of these medications and not have to wait for them to come from pharmacy. And this really helps in getting these meds in within the hour. So things like ampicillin, gentamicin, vitamin K, starter TPN, the first caffeine dose, and really putting the power in the hands of nursing to calculate these doses and draw up these meds. Ideally, we will train student nurses, bedside nurses, PCTs to set up a UVC, UAC tray in the room. So it's flushed, ready to go. The baby can be put in the bed, and then we can start lines sort of immediately as soon as the baby gets here to meet all of our golden hour sort of requirements for the best patient outcome. It's very helpful to assign delivery team roles prior to going to delivery. So somebody's saying, I have the head of the bed. Somebody's saying, I'm going to put the baby in the bag. I'm going to hold the stethoscope and check the heart rate. All of that, there's a much better patient outcome if all of that is assigned prior. And then obviously per NRP guidelines that Dr. Capriolo teaches all of us so diligently, checking all of your equipment before you start. So in the delivery room, as I think everybody here knows, preterm newborns, especially ELBWs and VLBWs, are at particularly high risk for anemia. So we do try to do delayed cord clamping for 30 seconds. The formal recommendations, you can go up to 3 minutes, but we don't do that. I have not seen that done here. But delayed cord clamping is associated with a decreased need for postnatal blood transfusions, decreased rates of IVH, decreased rates of NEC. And so all of those things affect the neurodevelopment of the infant. There's not great studies or not enough studies on the safety of performing delayed cord clamping in all infants, even those who require active resuscitation. So the NRP formally recommends 30 seconds of delayed cord clamping in term and preterm infants who don't require active resuscitation immediately after birth. Hypothermia. So this is one of the biggest things that we are trying to prevent in the golden hour. It's defined as a temperature of less than 36.5 degrees Celsius. I know that a lot of the nurses on here are probably thinking, and the attendings as well are probably thinking, well, gosh, that's a lot of our patients. We are doing our best and continue to sort of fine tune the interventions that we have to decrease our hypothermia rates. But nationwide, the prevalence is between 45 and 93%. So it's a huge problem with huge implications. And that goes up or down depending on gestational age and birth weight. Each degree of temperature drop is associated with a 28% increase in neonatal mortality. So it's certainly not insignificant. It's certainly not a matter of just warming them up. We want them to be warm and have stayed warm from the time the cord is cut until they get to the NICU. There's a question. Oh, Jenny, I'm going to let an OB answer that as soon as I'm done.
Okay.
So hypothermia, again, it's not just being cold and needing to get warmed up. It is associated with significant morbidity and mortality. It's a delayed adjustment to newborn circulation. So you have a persistence of the ductus arteriosus, higher rates of hypoglycemia, higher rates of metabolic acidosis. That can result in significant coagulopathy, prolonged oxygen dependency. It by itself is a risk factor for development of IVH, which I know we've discussed a lot today. It increases the risk of late onset sepsis, long-term neurodevelopmental disturbances, and even death. And even for our non-preterm babies, hypothermia in and of itself can precipitate a pulmonary hypertensive crisis, even in a term baby. So it does not behoove us to let anybody get cold, and we should be paying very close attention to that. Lots of strategies. I think that you're all familiar with most of these. We pre-warm the resuscitation table, whether it be resuscitating in an isolette or on the radiant warmer. We pre-warm and humidify the isolette in the patient's room. We would like to maintain the delivery room temp between 25 and 28 degrees Celsius, but Obviously, that has implications on our OB team and the mom, but somewhere else that we can focus on as well. We do use heated humidified respiratory gases for resuscitation. We use a polyethylene wrap or a neo wrap. In more resource poor areas, we use food grade plastic bags or saran wrap. They have made a huge difference worldwide in neonatal mortality just from hypothermia. We use an insulated head cap or hat. We have recently moved from the cotton hats for ELBWs to a hat that I'll show in the next picture. The exothermic heated mattresses, which we're using, and you do have to monitor. It's not an issue that we run into frequently, but you do have to monitor closely for hyperthermia that can result from those mattresses. And then I don't think a lot of people think about it. Our OB nurse, L&D nurse colleagues, I think probably think about it the most. When we're in a C-section or even a vaginal delivery, keeping that door closed to the room, because drafts, being under an air vent, all of those things can really quickly make the baby cold. So this is a little different. I think we have had this one here, but a neo wrap, so the baby's in the bag on a warming mattress with an insulated cap on. The leads are on already in the bag, and the bag is zipped up. So everything that you need to do in the delivery room, whether it be auscultate, readjust the leads, check pulses, all of that can be done through the plastic bag. It's just a thin membrane, and we shouldn't be taking babies out from it. This baby apparently also has an ostomy, but not relevant to today's talk. It was born with an ostomy. So in the delivery room, again, just to sort of summarize, thermoregulation, we want the baby in a plastic bag, a plastic lined hat, and on a thermal mattress. We do want to prevent hypoxia, which affects neurodevelopmental outcome. We start with 30% FiO2 per NRP guidelines for preterm infants, and then wean per NRP, wean or increase based on your SAT goals. We want early and accurate cardiac monitoring. We want to make sure we're perfusing our end organs. So one of the ways that we did this in the initial Golden Week protocol was to have the leads exposed, sticky side up in an arc on the bag, with the bag open, put the baby in, the leads were on the back, they picked up just fine, put a pulse ox on and closed the bag. And then you want to secure an airway, and that doesn't have to be just intubation. More and more, we are trying to bring babies down, even ELBW babies down on CPAP. Early CPAP exposure decreases the rate of future intubations. I know that everybody here has heard by now of our Keep the Peep initiative to decrease the need for extubation and also decrease our rates of chronic lung disease. So we want to start with that intervention in the delivery room and only intubate if we absolutely need to. Here are our NRP oxygen saturation values. So 60 to 65 for a minute of life, increasing by 5% intervals all the way to 10 minutes of life. So you're not really expected to be at 85 to 90% until 10 minutes of life. So we don't need to be cranking up the oxygen prophylactically and exposing them to high oxygen levels. So once the baby's in the NICU, I know that some nurses have seen some of the attendings when we bring down a baby. We are not trying to be rude. We're not trying to step on anybody's toes by telling you to just get the weight, length, and admission temp. We just want, that's the only thing that's pertinent in the first hour. We need the weight to calculate the umbilical line depth. We want an admission temperature, obviously, to prevent hypothermia and intervene if needed. We need the leads for vital signs. And then we want the nurse to step away and let the central lines go in. So we do want to provide efficient delivery of glucose and amino acids. We would prefer a UAC and a UVC. And this is not to say anything bad about the residents, but we prefer that those are placed by a nurse practitioner, or I should say an APP, a fellow, or an attending. These are not the babies who residents and interns should be practicing on. they're welcome to watch, but there needs to be a fellow and attending or an advanced practice provider, because we want to get these lines in, we want to get them in efficiently and as quickly as possible so that the babies are not exposed to cold temperatures for any longer than they need to be. Just because of the risks associated with them, we prefer no low-lying UVs, but sometimes, as we've all seen, that's all that you can get. So we really try to get a central UVC. The baby should be in the plastic bag during line placement, ideally. It takes about an hour, sometimes longer, for babies to really equilibrate to the environment and get to a steady state temperature. And that almost never happens before an hour of life. And lines should be in by an hour in the golden hour. So we should not be taking these babies out of the bag. It's very easy to just cut a hole, expose the umbilical cord, and leave the babies in the bag. Other criteria, we only want them removed from the bag when the skin temp is greater than 36.5 and the incubator reaches 80% humidity. And then again, something that we're working toward here, but optimizing respiratory monitoring, non-invasive respiratory monitoring, so decreasing the need to do heel sticks or access the arterial line every hour, placing a ceramic transcutaneous CO2 monitor. They are validated in infants as low as 22 weeks gestation. And it's important, the ceramic are associated with less skin burns and easier to calibrate on that extremely preterm skin. So we do want the respiratory therapist in the room early on, putting that on, even as lines go in. Hypoglycemia is something else that we are trying to prevent. Even transient hypoglycemia, so that one value, your glucose drops to 23 in the first hour of life. That can lead to lasting neurologic impairments, and we really want to set these babies up for success. So we want to start IV fluids, ideally through a UVC, so we can get that good concentration of glucose and amino acids in. We want to have that in and running by the first hour of life. If the baby has some cord anomaly, if nothing will pass and you keep false tracking, then a PIV is absolutely acceptable, but we prefer central access. To optimize future growth outcomes and decrease the incidence of hypoglycemia, the fluid should contain not only dextrose, but also protein. So very often in these babies, we'll do starter TPN. Sepsis is one of the most common causes of neonatal morbidity and mortality. I think that we all know that. ELBW infants are at particularly high risk. Sepsis alone puts patients at higher risk for cerebral palsy and PBL. Antibiotics, where they're indicated, should be given within the first hour of life. So I think that we have a nice idea of when babies are at high risk for sepsis. If mom has choreo, obviously, if the baby was delivered via C-section, mom was unruptured for purely maternal reasons, we may not start antibiotics, but in babies who we're going to start antibiotics on, they should be given within the first hour of life through that access that you've established. And it is helpful, again, to have these antibiotics stocked in the Pyxis so that the nurses can draw them up as soon as they're ordered. But keeping in mind not to go too far in the other direction of the pendulum, we don't want to overuse antibiotics. So equally as bad, if not worse, is overuse of antibiotics. They have very bad long-term outcomes if babies are exposed to too many antibiotics. So our new protocol is to stop antibiotics after 36 hours of negative blood cultures, which has helped babies lose 1 dose of GENT and 1 dose of AMP exposure. So this overall is our neonatal golden hour. Birth, obviously, is the 0-minute time. It's when the hour starts. The resuscitation ideally should take 10 minutes for you to get the baby stable enough to get in the transport isolette and go down to the NICU. It's a little bit of an overestimate here, perhaps, that it takes 5 minutes to get downstairs, but we do have to take an elevator. Sometimes it takes a little bit longer. So 5 minutes to get the baby from the delivery room to the NICU room and in the isolette that he's going to be in. Lines, really, we have to get faster at putting in lines, faster and more efficient. They should take about 25 minutes. There's a question in the chat. Thank you, Dr. Okoli. X-ray and starting of IV fluid should be done by 1 hour of life, and the isolette should be closed. I realize that there are a lot of barriers and sort of some of the biggest things that impair golden hour functioning are that we have to really modify a lot of processes. So we have to have X-ray on board. We have to have them be able to be there almost as soon as we get in the unit, waiting until we say, hey, the lines are in, let's confirm them. And then if you have to adjust them, that takes more time. So we really need ready access to X-ray technicians and X-ray machines. We also need to work closely with pharmacy to see what meds we can get in the unit, have them available in the Pyxis. And so all of these are challenges, but not ones that are insurmountable, certainly. So Natalie asked me to talk a little bit about sort of the golden week. So this was sort of trademarked and developed at the University of Alabama at Birmingham between 2015 and 2017. The goal going into this was to reduce the rates of severe IVH, so grade 3 or grade 4 as the primary outcome. What it encompasses is standardizing every facet of care, not just in the first hour of life, but only getting labs twice a day, what labs we're getting, what meds we're exposing our baby to, how often we're doing hands-on cares, when we're doing head ultrasounds, what our fluid limits are, what levels of sodium and potassium are we comfortable with, what we're putting in our TPN, not giving bicarb. So everything was standardized. It was very much a micromanagement of these babies' first week of life. We tracked down to the partial ml, how many mLs of blood were drawn per day and per week. And so the primary outcome being reducing severe IVH grade 3 or grade 4, we reduced our rates from 20.4% to 10.3%. So almost a 50% reduction. These, I will say, this data included babies as low as 21 weeks and 5 days, because the place where it was implemented routinely resuscitated 22 weeks, all 22 weekers, and some where we weren't sure of the gestational age. So those were all included in this data, and still it was nearly a 50% reduction in grade 3 to 4 IVH. Combined death or severe IVH in the first week of life was reduced from 26.5 to 22%. And in 2017, there's an award called the Gage Award for Innovation and Excellence from America's Essential Hospitals, and the unit at UAB was awarded that award. The publication is finalized. It's just waiting the next edition to be published. So it should be out and we should have more data. This was supposed to, I don't know where it went, I think. So this was about IVH risk. It was supposed to be before this last slide, but I can talk about it now. So 30 to 40% overall risk of IVH in ELBW infants, so very much higher than a baseline term baby. 90% of IVH occurs in the first 72 hours, and most of that occurs in the first 24 hours, most of that risk. Some of the factors leading to increased risk of IVH are capillary fragility, just by nature of being premature. Mechanical ventilation is an independent risk factor, and that is increased further by repeated intubation attempts. So if we're going to intubate these babies, they need to be done by an experienced provider, ideally on the first attempt. Sepsis, increased risk of IVH, any derangements in blood pressure, low APGAR scores, hypernatremia, really greater than like 158, 160, hypothermia, as we've talked about, and then early blood transfusions. So all of these things we can start to address in the golden hour. And I really am not sure how that got to the end. And then just as some motivation for you all as we take care of these ELBWs, this is a little girl named Cruz McCarley, and she was an IVF twin who was born at 21 weeks and 6/7 days. And she is now 7 years old and clearly thriving. She has some mild cerebral palsy and she wears braces on one of her legs. But other than that, she's very developmentally appropriate and on track with her age appropriate peers. And there's something in the chat. if anybody has questions. Hi, Dr. Diaz.
Thank you very much, Dr. Schofield. That was fantastic. And thank you for sharing that beautiful picture of that baby. That is impressive. 21 weeks. I don't know how I feel yet about that. But
I am not advocating for resuscitating all 21 weekers. My point in showing her was that if it can work for a 21 and 6/7 weeker, certainly we can make the difference for the babies that we are routinely resuscitating here.
yeah, absolutely. So I think, all the different things, the goals of the golden hour and the golden week. Give me just 1 second. I can let Johnny enter. What do you think is the biggest hurdle of getting this done in every single ELBW baby here at the university?
What do I think is the biggest one?
Difficulty to get.
I don't think it's one. I think that the hardest part of the Golden Week is that it's so multifaceted. So it really took buy-in from every single, it took buy-in from the PCTs, the charge nurses, the bedside nurses, extensive training on kind of why this was important. And once you have all that, it functions like a well-oiled machine. If I had to pick the most sort of difficult thing, I would say addressing staffing shortages, such as radiology techs, because you're not going to use your lines if it in an hour, if it takes you 2 hours to get a stat X-ray. So really having buy-in, and not that the radiology department doesn't think that this is important, but they physically don't have enough people to kind of be there at the bedside for every ELBW that we have. It would be nice, it would be lovely if we had our own radiology tech and X-ray. We do have our own X-ray machine, but if we had our own tech that was dedicated just for the NICU, or someone that was shared between the NICU and the PICU, I think that would help. It's been really easy to work with pharmacy here, so I think that wouldn't be much of a hurdle, kind of getting those meds within the hour. But certainly I think just the integration of all of the different departments that are involved is a challenge. Yes, I do think ultrasound guided line placement. I don't could help with the issues about getting X-rays. So Natalie asked, do I think that ultrasound guided line placement could help with the issues with getting X-rays for line placement? For sure. We have a point of care ultrasound in the unit. Our hurdle to this point is that very few of the attendings are trained in point of care ultrasound to the point where we could legally sort of be protected if we read a point of care ultrasound ourselves for a line being in the right place. I think in the long term, that would definitely help. I would also hope that in the long term, we improved our staffing issues, but I certainly think that point of care ultrasound is the way of the future in decreasing radiation exposure. Yes, so let me, can I share one more screen, Natalie?
Absolutely. And to Joni's point as well, I think having that table that you have up just with the timelines, just having that even in the DR is helpful, because it's even hard to keep time when you're just doing a recess, let alone trying to make sure it's all under 10 minutes and getting ready for transport. But that's
absolutely
a good reminder, having that table up.
Yeah, and so part of how this functioned really well, even the secretaries or the clerks at where I previously was had great buy-in. So as soon as they heard, they were involved in the huddle, as soon as they heard that there was a Golden Week baby coming, I'm just going into the Golden Week PowerPoint. As soon as they heard that there was a Golden Week baby coming, they went to the room where the patient was going to be admitted and put up all of the tracking measures associated with the Golden Week. And they also put a cling film on the door so that everybody in the unit, even cross-covering nurses for other nurses' lunch break, would know that this was a Golden Week baby between this day and this day for these 7 days, and to treat it accordingly. So there
are so many good inputs from in the chat. Using a timer from the isolate will help as well, says Lauren. I think it seems like we should find a task force.
COVID, I'm just going to share this really quick and scroll through really quickly to to some of the stuff that we. So this is the cling film, maybe. So this film was put on it was a cling film, it stuck to the door. We have the same sort of glass doors, we could put it on there, put it on the window. And it's just said, I am in my golden week. Can you see this?
Yes.
So it says the day that it started and the exact time. And that's another thing for the golden week. So it's not, everything does change. So we kind of routinely get our labs at whatever time, 4 o'clock, 5 o'clock in the morning. The labs in the golden week are strictly timed 12 hours, 24 hours, 36 hours, 48 hours. So it doesn't matter if that falls within the normal lab draw time. We would be sending them when this baby was specifically 12 or 24 hours. So everybody knows. So that one in the window of the door. There's everything, like I said. So this was for nursing documentation, and this was put in every patient's room, several of them obviously, but it would show the date and time of every lab draw, what labs were drawn, the source of blood that was used. So whether it was from an umbilical line, a venous line, an art line, a heel stick, and then how many times you had to stick if it was from a heel stick, and the amount of blood that was withdrawn. So in the preemptive studies to see how much blood we were saving by doing these limited lab draws, we were limited by the fact that a lot of the labs were from a heel stick, and we didn't know sort of how many, if they got all the blood on the first stick, or if these kids were having to get stuck 3-4 times to get enough blood. So we really tried to track that closely, and the nurses were instrumental in that. So these were in every golden week room. And then the fellows rounded every day, twice a day, by themselves on these babies, and all of these boxes were checked. Did you review the hematocrit? Did you look at any sedation goals? We were on a vitamin A protocol then for this particular one, but how often we're getting ABGs, our PCO2 goals, 45 to 60, is that addressed if they weren't within that? Was the weaning plan reviewed? So this was done every day by the fellow or a nurse practitioner, just somebody who was experienced, but it was filled out and handed off. So the daytime fellow would hand it off to whoever was on call at night so that it could be continued at night. Yeah, so those were some of the things, but certainly we could put the golden hour algorithm at the bedsides.
I think it's a great idea for that, especially it kind of promotes a shared mental model, right? I don't think everybody knows like the comment that you made that like a nurse wants to get all her stuff done for the admission, but they might not realize the priority about getting the lines and how long it's going to take to do that. So they should limit their measurements and whatnot. So having those guidelines, time suggestions, it will be helpful for everybody involved.
Absolutely. Yeah, and like I said, it really took a lot of buy-in. We had a nurse actually named Kim, who her only job was to do these training exercises, and she came in at night and she was there during the day, and she came in on the weekends, and she just did these PowerPoint things to stress to her fellow nurses, to RTs, why this was important. And really, I have to say that everybody in the unit, from the secretaries to the attendings to the subspecialists to the radiologists to the pharmacists, all bought in and were completely dedicated. And whenever somebody said a golden week baby's coming, it was just a cascade of events that happened. And I certainly think that we could accomplish that here. COVID has delayed things and thrown a wrench in things, and staffing issues are another issue, but I think in due time we could get it done.
I agree. I think another limitation is the fact that we are in this 4th floor and our OB is in the 6th floor, and the idea of surfactant delivery within the delivery suite still limits the time that it gets for us, like admission time to the unit. But certainly something worth doing. Similarly, sometimes I cringe every time I see the way that we measure the length in these infants.
With the
very,
marker on the blanket.
yeah, very early on. And, we know that keeping the head neutral, limited stimulation, manipulation of these ELBWs correlates with the indices of IBH. So
Absolutely.
So lots of interest for this. So hopefully we will get a team together and get it moving.
Yes, Anita has already texted me to be on the next meeting.
Fantastic.
Thanks, everyone.
Thank you very much, Dr. Schofield.
Yes, thank you. And so, hello, Dr. Hussey-Gardner just popped up. So we will just go ahead and roll right into her presentation on neurobehavioral development.
And Natalie, I want to make sure you guys are seeing my screen okay?
Absolutely.
Okay, great. Thank you very much. So thank you, Natalie and Dr. Diaz, for inviting me to talk today. I do have a couple of disclosures to make. First of all, over the past 2 decades, I've received $3.8 million from the Baltimore City Health Department and Maryland State Department of Education in support of Maryland's Pride, which is our premature infant developmental enrichment program that we do in collaboration with the Baltimore City Infants and Toddlers Program. I'm a member of the Baltimore City ICC, which is Interagency Coordinating Council that advises and guides how Baltimore City runs its program. And I chair the Maryland State ICC, which advises and guides how early intervention runs in Maryland. I have 3 objectives for the information that I'll be sharing with you today. One is to talk about some red flags of neurodevelopmental delay that we can see in infants at the time of discharge from our NICU, to share information about our NICU follow-up program and programs importance, and then talk about early intervention, and then more specifically, early intervention in Maryland, which is known as the Infants and Toddlers Program. With regard to the red flags that we see in the NICU regarding neurodevelopmental delays, we see both positive and negative signs. So the presence of a persistently disorganized suck, or a preference for using one side or moving one side of the body more than the other that persists up until the time of discharge, excessive arching of the back or body, a baby who has excessively hypo or hypertonicity, babies that are excessively irritable and very difficult to console, as well as babies where we're seeing sundowning, are concerns for developmental delays. And as this diagram depicts, it's not just the presence of one alone that is ultimately very concerning. It's when we see overlapping of some of these signs. Negative signs include the lack of a response to loud noise, a lack of response to a visual threat, or no meaningful eye movements, a lack of response to bright light in the pupils, babies who are not able to even maintain the briefest periods of alertness, babies whom we are not seeing multiple primitive reflexes, and babies who lack body movement. Again, it's the overlap of some of these positive and negative signs that will increase our concerns dramatically regarding the potential for future developmental delays. We also know that there are numerous diagnoses in the NICU that are associated with future developmental delays, and these include a birth weight of less than 1,500 grams, chronic lung disease, symptomatic congenital infections, severe congenital malformations, severe encephalopathy or HIE, fetal alcohol syndrome, a gestational age of less than 32 weeks, hearing impairments, hydrocephalus, inborn errors of metabolism, significant intrauterine growth restriction, grades 3 and 4 IVH, neck requiring surgery, NAS are neurodegenerative disorders, PVL, seizures, stroke, and vision impairment. But I think one thing that's really important to be mindful of is that the overall outcomes of these children are going to be influenced by social determinants of health. So looking at the adverse childhood experiences that a baby may experience, the social economic status of the family, as well as other demographic characteristics like level of parent education, all will combine with these neonatal morbidities to ultimately determine the outcomes of these children. NICU follow-up programs are the cornerstone of standardized high-quality care provided to newborns at risk for future neurodevelopmental delays. Now, programs exist across the country and across the globe, but they vary dramatically. They vary depending on the goals of the program and their resources. As such, each program is going to have its unique eligibility criteria and unique processes that they will follow. At the University of Maryland, our goal is to provide ongoing evaluation and guidance related to the health and development of infants at high risk to make sure that they develop to their best ability. We have 4 aims. The first is to ensure specialty care follow-up. A lot of these babies that leave the NICU leave with multiple subspecialty appointments scheduled. We want to make sure that they are attending all of these appointments and facilitate that if necessary, in addition to sometimes identifying new subspecialty follow-up that is needed depending on how the health and the development of the child progresses. We want to identify delays in development or atypical development as soon as possible. We know that the earlier we begin intervention, the better the child's outcome is. We provide individualized parent education and support. So depending on how the child is doing at that specific visit at that point in time, we are going to provide the family with suggestions on things that they can do to foster their child's development at home. And we will connect them with resources in their community, such as the Infants and Toddlers Program, Early Head Start, Story Time at the Library, Locate, WIC. So there's a variety of community resources that will make sure that children are connected with that will help meet their individual needs. Our NICU follow-up program has a 2-tier process. Tier 1 involves neurodevelopmental screening, and our team is composed of an attending physician from either neonatology or gen peds, a developmental specialist, and I serve in that role, and our neonatology fellows. We do developmental and other screenings. We do the Best Beginnings developmental screen, the MCHAT, which is the modified checklist of autism in toddlers, the revised version. We do the Edinburgh postpartum depression screen and a food insecurity screen, a medical review with the family, and a physical and brief neuro exam. In Tier 2, our team is composed of a developmental pediatrician and a psychologist, and they are going to do neurodevelopmental assessments and provide diagnoses. The tests that they use include the CAT-CLAMS, which looks at cognitive and language development, the ADOS, which is the gold standard for assessing and diagnosing autism spectrum disorders, the Bailey, the Vineland, and they do neurophysical exams, Dr. Badawi does. Between our 2 individuals, Dr. Badawi and Dr. Kane, they do diagnose ASD, cerebral palsy, intellectual disabilities, and specific developmental delays. In addition, Dr. Kane, our psychologist, offers consults, behavioral consults. She'll meet with families to help them process a big diagnosis. And for our families that might be struggling with mental health issues, she can meet with mom or dad one time to really help determine what type of therapy, what type of intervention would best meet their needs, what is available in their community, particularly what is available that accepts the family's insurance and meets the style of the family, whether it's group, one-on-one, or virtual internet-based. Our eligibility criteria for our 2 tiers differ. For Tier 1, it's a birth weight of less than 1,500 grams or a gestational age of less than or equal to 32 weeks, as well as any of our babies with an abnormal neuro exam at discharge, APGARs of less than 5 at 5 minutes, chronic lung disease, congenital anomalies, congenital infection, hearing impairment, HIE encephalopathy, hydrocephalus, significant IUGR, grade 3-4 IVH, meningitis, microcephaly, porencephaly, PVL, seizures, strokes, twin-to-twin transfusion syndrome, ventriculomegaly, and vision impairment. In addition, we are seeing babies born to moms who are COVID positive for a one-time visit at 1 year of age. For tier 2, our psychologist and developmental pediatrician will see babies with brain injury, HIE, or seizures with significant concerns on their neuro exam, whether those concerns are noted in the NICU or at a subsequent NICU follow-up appointment. Babies with genetic conditions associated with developmental delay like trisomy 21, diagnosed developmental delays, or moderate or severe concerns on the best beginnings developmental strain, children who are diagnosed with an autism spectrum disorder or who fail the MCHAT with concerns for autism. And then parents who have identified concerns related to depression can have a mental health consult within tier 2. With regards to the infants and toddlers program, early intervention falls under the federal guidance of the Individuals with Disabilities Education Act, and that was added to federal legislation in 1990. There are 4 primary goals of early intervention. The first is to enhance the child's development. The second is to minimize the potential for delay and need for special education in the future. The third is to support the family in promoting their child's optimal development. We know that parents, grandparents are their children's first and best teacher. And if we can empower them and their skill set to work with their child and enhance their child's learning, we hope that that stays a skill for them for the rest of their life. And then we want to facilitate the child's participation in the family's normal routines and that of the community, such that they can be engaged in the same types of activities as a child without a delay or disability. Now, under the Individuals with Disabilities Education Act, every state can choose who their lead agency will be to run that program. The 2 most common agencies are education and health. Arizona, however, took a different route, and their lead agency is the Department of Economic Security, and I'll tell you why in a moment. Every state gets to name their program. The names vary greatly. The 2 most common are Infants and Toddlers Program and Early Intervention. However, there are a number of states where they call it First Steps or Early Steps. There are over a dozen different names for early intervention. Every state gets to define what makes a child eligible for program participation, and they can include in their definition of eligibility the percent or standard deviation delay required, what, if any, high probability medical conditions will make a child automatically eligible, whether or not to serve children with atypical development, and if so, how will that be defined, and whether or not to serve or track children who are at risk. Finally, states can determine if there is a fee to participate in the program or if there will be no cost to families. Now, there are 5 states that are birth mandate states, meaning that when this piece of legislation became part of the Individuals with Disabilities Education Act, those 5 states were already offering services. And in Maryland, we were already providing services and providing them for free. So Maryland is considered a birth mandate state and must be provided at no cost to families forever. All other states that are not birth mandate states can choose from year to year. Services can be provided at no cost by billing public insurance. And in Maryland, we do bill medical assistance. That is the only type of revenue that we can generate other than federal and state dollars or grants that we obtain. Some states provide services at no cost to families while also billing private insurance, but not receiving co-pays or deductibles. We are not allowed to do that in Maryland. Finally, states that have cost to families some of them choose to do what is called the family participation fee. And that can be a one-time fee, it can be a monthly fee, it can be a per service fee. However, the eligibility evaluation to determine whether or not a child can receive services must be free in all states. Some states also bill private insurance and collect co-pays and deductibles. I have a map of the United States that tells us this information for every state, but because of shortage of time, I'm going to concentrate on Maryland, and if we have extra time, we can talk about the states that surround Maryland. In Maryland, the lead agency is the Maryland State Department of Education, and we are called the Infants and Toddlers Program. To be eligible by a delay, you must exhibit a 25% delay in one or more domains of development. And if a baby is born prematurely, the baby's adjusted age is used until the child's adjusted age is 12 months. There are over 400 high probability medical conditions in the state of Maryland, and we have CRISP alerts that do exist for these. The one that we most commonly use in the NICU is a birth weight of less than 1,200 grams. Other NICU high probability medical conditions include chronic lung disease, symptomatic congenital infection, severe congenital malformation, severe encephalopathy or HIE, severe epilepsy, fetal alcohol syndrome, hearing impairment, inborn errors of metabolism, grade 3 or 4 IVH, neck requiring surgery, NAS, neurodegenerative disorders, PVL, and visual impairments. And as a result of some studies that were done out of our NICU follow-up program and a result of some work out of the Division for Early Childhood of the Council for Exceptional Children, which is the parallel of the American Academy of Pediatrics for Early Intervention, there is a recommendation that we serve or at least track all babies born weighing less than 1,500 grams. So recently, the Maryland Infants and Toddlers Program put in a new policy whereby children who are born between 1,200 and 1,500 grams who are not otherwise eligible, meaning they don't have a 25% delay, they don't have atypical development, they don't have another high probability medical condition, they can qualify for tracking, which means that the Infants and Toddlers Program will call the family on an agreed upon frequency, it's usually quarterly, to conduct some screening. The goal is that we will identify and find these children earlier by keeping tabs on them versus not having them be part of the system at all. In Maryland, we do serve children who have atypical development, meaning they may be doing what they should be doing when they should be doing it, but not how. And clinical opinion is counted as the rationale for that eligibility. This is the website for the Maryland Infants and Toddlers Program, referral.mditp.org. I highly recommend that you guys bookmark this and share it with families. It is a wonderful website. It tells families all about what developmental milestones to expect at different ages. It gives them a link to download an app from the CDC that helps them track their child's developmental milestones. It explains what the Maryland Infants and Toddlers Program is all about and gives some outcome data, as well as providing a means for making a referral. As professionals, if you use this website to make referrals versus calling or having the parents call, you will get notification back as to whether or not the referral has been processed, or if they're already in the program, or if they're not able to contact the family. There's a 5-year plan to turn this into a community compass. At the end of the 5-year outcome will be that with parent permission, providers will be able to access information such as the Individualized Family Services Plan. In a longitudinal study recently completed by the Maryland Infants and Toddlers Program, we found out that 68% of children who receive services from the Maryland Infants and Toddlers Program no longer need special education or related services by 3rd grade. Maryland is currently serving 21,005 children in the Infants and Toddlers Program. And a recent study came out to show that the earlier, the better, not only for outcomes, but economically. For every dollar that is spent on early childhood programs, including early intervention from birth to 5, depending on the study you look at, you will save between $4 and $16 in the life of the child. That is why Arizona has chosen the Department of Economic Security as their lead agency. And for the process involved, we as professionals should refer a child to the program as soon as we suspect that they may be eligible. The Infants and Toddlers program will call the family, and with family permission will conduct an eligibility evaluation. At least 2 different professionals have to participate in that evaluation. They need to look at all 6 domains of development. If a child is not eligible, the child will be referred to community resources as appropriate, perhaps Early Head Start, WIC, story time at the library. If a child is eligible, from the date of referral, they must develop the individualized family services plan within 45 days. Once the parent signs the IFSP, services have to start within 30 days. So if that IFSP is written by day 10, you still have to start within 30 days of that signature. Because babies and families change so frequently, it has to be reviewed every 6 months, new evaluations, and a total new plan has to be written annually. Once a child is no longer eligible, no longer delayed or have atypical development, they will transition. Children with high probability medical conditions are eligible until 3 years of age. If a child is no longer eligible, they will be transitioned into community resources. If that eligibility is no longer feasible because the child is 3 years of age, an evaluation will be done to determine if the child is eligible for Part B, preschool special education services under the Individuals with Disabilities Education Act. The rules change. You must have a developmental delay or disability that negatively impacts your ability to perform in a school setting to be eligible after 3 years of age. So if a child is found eligible, they will continue to receive services. If not, they will go to community resources. In Maryland, and only in Maryland, if a child is found eligible for services at 3, the family can choose to stay in the Infants and Toddlers program on an extended IFSP until the first day of school after the child turns 4, or they can go to special ed preschool. Once a family chooses to go to special ed preschool, they can't come back to the Infants and Toddlers program. And the choice of infants and toddlers or special ed only exists for families whose children are in infants and toddlers at the time that they turn 3 years of age. There are 3 evidence-based practices in early intervention that exist throughout the nation, and it is highest recommendations to implement these, and Maryland is doing so. The first is authentic assessment. So we have what we would consider typical assessments to determine a child's eligibility with delay or atypical development. Once a child is determined eligible, families will have an authentic assessment. An assessment that really looks at how the child is functioning during daily routines within their family. The most popular assessment is the routines-based interview. Based on that interview, they will see how the child is doing during their daily routines with the family and come up with family-centered functional goals that will result in the enhanced participation of that child in daily routines. So perhaps some of those verbal skills are impacting mealtime the most, and that's when they want to work on those skills. The second is coaching. So instead of getting on the floor and only working with the child, providers now get on the floor with the family and coach the parents on what they can do to foster their child's development during those daily routines. And primary service provider model has demonstrated the best outcomes for children. And in a primary service provider model, every child has a team behind them. So there would be a physical therapist, occupational therapist, speech and language pathologist, a special educator. In some jurisdictions, also a social worker or a nurse. The team gets together and discusses the child on a very frequent basis, but one provider from the team goes out into the home and serves as the provider for that family, providing very integrated suggestions. If the therapist feels that what is needed is out of their scope of practice, they may bring the other therapist in for a session or two who is a member of that team. So services in the infants and toddlers program are individualized, family-centered, culturally and linguistically competent, developmentally supportive, focused on the child and family strengths, evidence-based, team-based, and provided in the child's natural environment. Here are my references, and if there are any questions, I would be glad to take those.
Thank you so much, Dr. Hussey-Gardner. I think it's still my question, and I think we discussed this before, is what certain tools can we do in the NICU, start early on? And I know that you are quite involved with our babies at this moment, but things that can be done by the neonatologists or nurses to like have that. How can we be trained to get that red flag of babies to get you in to see them earlier?
So I think one thing that's important to know is we have an outstanding rehab team who is in there, and they are seeing all of these babies on a routine basis. And then on Tuesday mornings during our interdisciplinary rounds, we are discussing these babies. And if there's ever a need for me to see one of these babies and it's not something already being addressed by PTO or OT or speech, or additional input would be valuable, that is identified at that time. I think things that are important to support the development of these babies are things like positioning that are going to be discussed next by physical therapy, but also working on brain development and language development is critically important because we have a single family room unit. And we know from research that there are many benefits to that, but there is a disadvantage to the children's development of the language portion of their brain. That's why we have brought Goslings to the unit. And one of the things I want to make sure that everybody is aware of is we do have a mini Goslings video. It's a 15-minute video that talks with parents about how to know when it's medically appropriate to add developmental stimulation for their babies in the form of talking and holding and touching and showing. And it also teaches them all about the signs for readiness or coping or approach, and being sensitive to baby signals is really important so that we are not understimulating, but we're not overstimulating these babies. And that's available, and any of our bedside nurses can pull up mini Goslings for the family. And we have a book that goes with that. So any family who watches mini Goslings will get a copy of a book, and they're taught how to use that with their family. We also have Goslings that is offered face-to-face, but because of COVID, limited to 5 parents, and we're doing that twice a month in collaboration with our partners, Port Discovery.
And I think it's probably too early to know, but are you aware of any data on the impact of COVID in parental presence at the bedside and that impacting the neurodevelopment in the NICU at early on?
I haven't seen any literature on that at all yet. So it'll be interesting to see what comes out of that. And I think we're also going to see that the impact of COVID goes beyond presence in the NICU, and we're seeing it in NICU follow-up. Just because, especially in the social emotional domains and their ability to interact with others, some families have really limited interactions to just their family. Some children are now approaching 18 months of age and haven't played with another child. So we're not only are we going to see impact, in my opinion, from less parent visitation in the NICU, but I think it's going to have longer term impacts because of their limited experiences overall. But children are resilient, and we got a lot of brain plasticity, so we're hopeful.
Just to piggyback off of that question, just because I see we have a couple of our rehab on right now, and just wondering if they've seen anything come out or any experiences that they've had with the same thing. But we'll give Elena time to answer that since she's our next presenter anyway. So with that, thank you again, Dr. Hussey-Gardner, for that talk. And if we have any questions, we'll shoot them to you. And with that, Elena, we'll have you hop on, give your 2 cents, and then just go ahead and pop into your presentation.
Sure. Yeah. Like what Brenda said, I haven't seen any specific like research or longitudinal studies looking at that impact of COVID quite yet. But, you know, we are definitely seeing like the benefits of kangaroo care, having the parents present, having them follow up is definitely impacted by their inability to be at bedside. So, and then also just with having to wear a mask and these babies not seeing facial expressions, I would anticipate that it would, you know, impact their social development. But I also haven't seen anything formal in the literature.
Wow, it didn't cross my mind about the facial expression and the impact that can have very early in the NICU. Oh.
Yeah, unfortunately, and especially when they're here for a prolonged period of time. And you know, parents try to take their mask down if they're here and they're in the room, but a lot of times, especially if the parents can't be here, they're not seeing any faces.
And for me, I'm really impressed by the resiliency I'm seeing with the youngest of our babies in NICU follow-up. In the very beginning, the masks were very scary to them. And now it's mind-boggling that the babies are being able to read our eyes and they are smiling like when we smile and they can't see our smile. So they're getting really savvy at reading eyes and foreheads in a way I think we never could before. But I agree with you, Elena. They're going chunks of time without seeing their families' faces, and that can be challenging.
Yeah.
Yeah, that comes with questioning things like a lecture, like reading, and this exposure to TV that we always have thought about, the feedback, like why TV is not developmentally appropriate within the first 2 years of age. And now it makes me wonder that is that the same effect that you could see potentially with the mask?
Right.
Okay, sorry, not interrupting anymore.
Oh, no, that's good.
Elena, has there on the rehab side been any thoughts on or progression with the clear mask for some?
Yeah, so actually, Allie, our speech therapist, it looks like she put something in the chat. She said she doesn't have a mic. She said there was a study showing that infants born during COVID scored lower on the DAISY, but a major confounder was post-COVID. The test was delivered with masks on, so they felt like it made a bigger difference. And also Allie has gotten some surgical quality clear masks that she's been using mostly with our outpatient population to help, especially with her language patients. So that has been a tool that she's been able to use. She said, unfortunately now with the KN95 requirement, we can't use those. So that's a very good point. I know it looks like we're a little ahead of schedule. Did you want me to go ahead and start or wait a few minutes?
No, you can go ahead and get started.
Okay, I'm going to share my screen. Okay. All right, so I'm Elena. I'm one of the physical therapists here, working in the NICU and all of pediatrics here. So I'm going to discuss with you some of the things that we can do as a NICU team to promote neurodevelopment in this population. So looking at our kids that are at high risk for brain injury and also those who already have diagnoses that are consistent with brain injury, such as HIE. I'm going to go into some of them in more detail, but that's going to be the focus of my presentation. Okay, so like I said, some of the things I want you to get from this presentation are to understand the developmental consequences of some of these diagnoses. I'm not going to go into detail about them since by this point you're probably familiar with these listed here, but they are some of the ones I'm going to focus on. Of course, there's also neonatal stroke and some other causes of brain injury that would have similar outcomes and similar presentations, but I'm going to focus on these 4 since we tend to see those most common. And then I'm going to focus on some treatment interventions that we can do in the NICU to help not only reduce the developmental consequences, but in some cases actually reduce the severity of the brain injury. So we're going to start with IVH and PVH. So looking at the initial clinical presentation, you're going to see impairments in self-regulation, state control. You know, they have trouble, these babies have trouble maintaining a quiet, alert state, which really affects pretty much everything. It affects their feeding, their muscle tone, their movement, their level of consciousness. So we're really seeing a lot of impairments in the initial stages. And then longer term, you see some impairments in neurosensory development, overall developmental delay, motor impairments, cerebral palsy, cognitive decline. And the reason for this is that IVH and PVH primarily affect the white matter that contains the motor tracts. And depending on the area of the lesion or of the bleed, the lower extremity tracts tend to be affected first due to their proximity to the ventricles. And then if it expands past that, it can have upper extremity involvement also. So bilateral cerebral palsy with lower extremity involvement tends to be the most common motor impairment that we see in these kids down the line. So similarly, then looking at PVL, that has been shown to be the predominant form of brain injury underlying a lot of neurologic morbidity, and it's the most common cause of cerebral palsy in preterm infants. It's more common in preterm infants, especially those with low birth weight because of their immature vascular supply and some of their impaired autoregulation. So this PVL has been found to be associated with cognitive impairments and visual disturbances. There was a study done of 25 children, 24 were preterm and 1 was term, and they had grades 1, 2, and 3 PVL. And some of the outcomes of that study, looking at them down the line, I have listed here. So we have spastic diplegia, quadriplegia, inability to walk. We had some that were able to walk independently at 36 months with lower extremity braces. And they found that most children with grades 2 and 3 PVL had severe neurologic motor abnormalities and severe psychomotor delay. So there were statistically significant differences found in this study in the motor impairments and walking ability between children with grade 1 and grade 2 PVL. So the severity of the grade really did affect the developmental and motor outcomes in this study. Now we're going to look at HIE briefly. So moderate HIE, the initial presentation we tend to see is lethargy, feeding problems. We can see high tone initially and seizures. And then long-term, it's been shown that these kids tend to present with bilateral cerebral palsy and upper and lower extremity involvement. Then if we have a more severe HIE, the initial presentation is more of a flaccid tone, seizures, and there's very similar long-term sequelae, which I have listed there. So they showed that infants with abnormal neurologic exam, neonatal seizures, abnormal EEG, which ties into that, and an abnormal MRI are at risk for poor developmental outcomes at 1 year of age, and they're often profound and multisensorial. So these are affecting, you know, pretty much every body system. So the main focus that I want to focus on is some of the interventions. So like, what can we do in the NICU as a team to help these things? Now we understand the presentation and the long-term outcomes of these conditions. So what can we do about it? What can we do to help? So things I'm going to focus on are therapeutic positioning, developmental care, and direct therapy services, and what our role is in addressing these impairments. So first thing will be therapeutic positioning. So as we know, in utero, in the 3rd trimester, it's promoting the physiologic flexion, midline positioning, hands together, head in midline, shoulder, hip, and knee and scapular protraction, that nice tilted flexed position that we like to see in our full-term healthy babies. That happens mostly during the 3rd trimester. So when we're having these preterm infants, they don't have the tone and strength to be able to do anti-gravity movements and really get into that nice flex posture. So they tend to present an extension. Preterm, regardless if they have a neurologic insult or not, tend to present in that extended posture and need facilitation to get into that flex posture. You'll also again see the impaired self-regulation, which can impact their feeding. It can impact their ability to just maintain an appropriate awake sleep cycle and their transitions between states. So that's when you have these babies that are either crying or sleeping and there's kind of no in between. And then we've seen down the line that this extension posture starts to affect the sitting posture, symmetries, hand function at 1 year of age. So it's something that does persist and does have longer term impacts than just in the neonatal period. And we noticed through some research studies that infants who are positioned appropriately demonstrate more variability in their movements, in the velocity and in the accuracy, and they bring those hands to midline more often. So the positioning has really been shown to positively affect those skills. There was a randomized controlled trial that was done, infants from 23 to 32 weeks. It was a level 3 NICU. They used the NICU network neurobehavioral scale to assess their developmental skills. And they found that effective positioning did reduce asymmetries in these preterm infants. So positioning was found to be effective. A little more detail about that. One of the things that we'll use for positioning is nesting and swaddling. So the use of swaddling and boundaries mimics that uterine environment. So during fetal development, the uterine walls provide containment, facilitated tuck, which is again that flexion I talked about, and pelvic tilt. And they promote extremity flexion, and the walls of the uterus provide reactionary forces that helps the babies develop appropriate muscle tone. So when they're born without that structure, that's when they get the extension and the lack of anti-gravity movement, and they kind of don't know how to organize themselves in space. So we found then that swaddling can help improve these things and improve their neuromuscular development, decrease their startle response, which ties into that state regulation. They've shown improved sleep, decreased stress, improved self-regulation, like I said, during handling too. So they're better able to tolerate their cares, parent holding, basically everything they have going on. They also showed improvements in the midline orientation, which I'll discuss a little bit more in a moment, and their movement patterns. And then it showed that with swaddling, infants with a cerebral injury actually cried less, which obviously less stress, better tolerance to handling, better state regulation. The use of firm boundaries. So that helps, again, like I was talking about with the uterine walls, providing those boundaries can simulate that environment. So that's going to improve motor behavior, improve postural development, musculoskeletal alignment, that improved movement across midline, and more variations in velocity, just more motor control overall. And they showed that it can also lead to decrease in the abrupt movements, so that smooth movement quality that we're looking for. Head positioning, you'll see that the PTs and the whole rehab department really focuses a lot on head positioning. And of course, it's for cranial symmetry, cosmetically, and for the impacts that cranial symmetry has on development. So the midline orientation that we're aiming for has been shown to be required for early reflex development of smooth movement patterns. It improves the symmetry, and it actually can help the hemodynamic changes in the brain. So there was a study that also looked at head-to-bed elevation. And in that study, so regardless of gestational age, 90% of PIVH occurs in the first 3 days of life from what this study had looked at. So they looked at the first 4 days of life. They randomized 180 infants into either flat supine with head rotation Q4 hours, or into an head of bed elevation at 30 degrees with head maintained in midline. So they had these two positions for 4 days. They found that the elevated group developed significantly fewer grade 4 hemorrhages and went to discharge quicker. So the head positioning actually did help prevent, or was at least associated with, lower grade brain injury. So it's something we can consider to help these kids out with not only addressing the impairments, but preventing the more significant impairments. So it showed that the elevated head positioning is also associated with a reduction in the cerebral venous pressure, which also helps, of course, with that. And we've seen improvement in oxygenation and hypoxemic events with the elevated head positioning as well. Another intervention that we provide is developmental care, which I'm sure you're familiar with in the NICU, includes reduction of environmental and tactile stimulation. We do this, the nursing staff and everyone in the NICU, by clustering cares, keeping the overhead lights dim, covering the isolates, maintaining adequate ventilation by not causing stress. So not suctioning the ET tube more than necessary, eliminating clustering labs, eliminating painful procedures, eliminating unnecessary handling to help with their state regulation. So this has been shown to promote neurodevelopment and organization and helps with their self-regulation, reduces infant stress, and it aims to strengthen that cerebral blood flow that's so important. So I listed here some of the things that I was just talking about that we do that can really impact this. So again, frequent adjustment of lines and tubes, repositioning, suctioning, these have all been shown to impact the cerebral circulatory fluctuations. And then the interventions that we provide from our department would be direct therapy interventions. So these are defined as services provided by a neonatal therapist. These include therapeutic neuromotor handling. So this is the handling techniques that we use to promote postural control, joint alignment, range of motion, symmetry, flex posture, midline orientation. And this has been shown to lead to improved anti-gravity and midline movements. You're seeing a trend here probably for the midline flexion is what we're really going for. We also provide multimodal sensory stimulation. So we try to provide positive sensory experiences to help with sensory development and sensory motor development. A lot of our NICU babies, unfortunately, they have to get heel sticks, they have to get lines placed, they have a lot of painful stimuli, and tactile sense is one of the first senses to be developed. So even our preterms, to some extent, are being affected by this painful stimuli. So one of our main roles is to provide positive touch and show these infants that not all touch is bad and help with their tactile system. And that's been shown to help again with state regulation, helps with PO feeds and shortened stay. One of the things we do to encourage this is neonatal massage. This helps with reduced heart rate, improve sensory motor skills, calming, improve state regulation, especially in addition to the neurologic population, looking at our NAS population as well. Massage has been very beneficial for their state regulation. Other things that we do, like I mentioned, is focused on cranial symmetry, feeding, modification of the environment to help address some of these overstimulation that we get in the NICU. So I went through that really fast. So if you guys have any questions, I can go through those right now.
Alana, thank you so much for that great presentation. First, I wanted to ask you, so right now you guys are seeing, you start seeing these at-risk infants at what, when? What age?
So we have standing orders. So, any infant that's born and comes to the NICU is going to have already a rehab order. Then we have some criteria that's been agreed upon that they meet. So any of these kids with any neurologic will meet immediately. So as soon as they're medically appropriate for us to get in there, we will start seeing them. So for example, for HIE, as long as they're done cooling and rewarmed, and we can get in there and see them. A lot of times we'll wait until EEG comes off so we can do a little more thorough of an assessment, but pretty much they just need to be rewarmed and medically stable.
And how often do you see them based on their needs, or is there a standard?
Yeah, so we use the NNE, the Morgan Developmental Assessment, And then based on those findings, we'll determine our plan of care. For this population, they tend to be our highest frequency. So we're seeing them more like 3 to 5 times a week, whereas some of the very little preemies that can't handle a lot of touch and handling will do more like 1 to 3 times a week.
And what is currently done? And like, I mean, I imagine your COVID had limited already, but in terms of teaching parents to studying in the NICU, because we know that earlier stimulation and training they get, the better the outcomes.
Yes, if parents are here, we include them as soon as possible. So even if it's a little 27-weeker in an isolate, we have parents, doing age appropriate things, teaching them what they can do for positioning. You'll see us a lot of times sitting up these little tiny babies. And of course, it's not to work on postural control or muscle strengthening, but just to give their vestibular system a sense of different position. So we'll show parents how to do that if they're comfortable. Parent involvement is huge. Absolutely.
Sure, I have another question.
Yeah, great.
No, are there any specific tools or resources that are used for babies who already have IVH?
So we use a lot of these same treatment strategies because it's very impairment based. So they will definitely meet our criteria to be on program with us. And then just based on our findings of their impairments, we will address each impairment.
Thank you.
Sure. I don't have the chat up. I don't know if we had other questions.
Not in the chat that I can see. I'm looking also.
I didn't see any other ones come through. So thanks so much, Elena, for coming and presenting.
Of course. Thank you for having me.
Absolutely. So just before we end things, Dr. Diaz and I just wanted to go through really quick a few things. Like we said, one thing's, and Dr. Diaz, if you want to just run through some of the initiatives that we are working on with our neonatal neurocritical care program.
And more than anything, we wanted to take the opportunity of having so many participants today to say that we are looking for volunteers to join our forces and initiatives in the neurocritical care team. Right now, this is the list that we have, but as you can see from all the talks that we have today, there's lots of things to work on particularly for our preemie population. But these are few of the things that we will be working. I think one, the pressing matters right now is IVH. We unfortunately have seen an increase of IVH and severe IVHs in our older babies. So we have been looking for more QI projects to help with reduction. And I think the fact that everyone enjoyed the golden week, the golden hour, is something we should start as soon as possible, because this is also goes along the lines of IVH reduction. We are also working and hoping to work with our radiologist colleague in the scoring system and be more formalized in that. Other initiatives are the use in we have been working over the last several months in bedside monitoring with NIRS and AEG. This is particularly important for the bedside nurse and providers. So lots of opportunity in that. If anyone is interested, please email Natalie or I about it. Other things that we're working on, and another pressing project is the feed and swaddle for MRI optimization. We have seen more difficulties on obtaining better quality images that makes difficult for diagnostic and prognostication purposes, particularly for babies who just this past maybe 2 weeks ago, we have this baby with posterior encephalocele, barely able to see these images. So that's another QI project that we could use some help from. Dr. Shaw, who's not here right now, Natalie and Elena, we have been talking about the implementation of using infant massage in preterm infants to improve neurodevelopmental outcomes. And this comes after we have been trained. So Natalie and I are now certified infant masseurs. Haven't practiced though. Another project is also, we have seen an increase in the use of narcotics in the NICU population. And more often than not, we are using fentanyl morphine as a way to treat this quote unquote agitation. And we know the impact of on the developing brain that these medications have. So that's another initiative, is how can we safely decrease the use of these medications in the NICU? And similarly to that though, we are looking about dexmedetomidine as a more promising drug in the use of preterm infants as an alternative, or maybe as the only type of treatment for sedation of these babies. Carrie says, I don't think I'm officially on the neuro team, but would love to be added and help as needed. Fantastic. And that's what we are looking for. Carrie, if you don't know, we meet every other Thursday, the odds Thursdays of the month, 1:30 to 2:30 p.m. And we will send a link again. Anyone is welcome to participate. We have discussion. We go through our patient, as well as having conferences, tip of the month, and many more things. So please join us when you can. We are also looking to promote the integration of integrative medicine team in the NICU. We have lots and lots of resources actually in the University of Maryland that are underused in the NICU population, and that includes music therapy, healing therapy, many different things that I think will be important for our babies as well as our parents. And Natalie Hunt had led the Cutler program for several years, and actually have also gotten grants for it. Fortunately, COVID also made an impact on that, and we're trying to spin it up a little bit now and do something we're planning to call a remote Cutler program. So this again is a limited, some of the initiatives that we are thinking of. Please send us ideas. Please let us know if you're interested in participating. The more the better in this case.
Thanks, Dr. Diaz. And just wanted to just also put in just another plug for the Neonatal Neurointensive Care certification. I know I've taken the certification. Dr. Diaz is planning to take the certification very soon. We're hoping to get just a good core of neonatal neurocritical care focused providers and nurses, and just everyone, just to kind of increase our number of staff members that are focused on neonatal neurocritical care, and certification is a great way to do that. So I just wanted to quick go over some of the eligibility. Any physician, RN, advanced practice nurse, RT, or neonatal therapist is eligible to sit for the exam with at least one year of work experience. The cost is $210, which hopefully some of the education money through the hospital can help cover. The certification maintenance is every 3 years. So as long as you have continuing education credits, that will go towards that. Here I just have a breakdown of the content, which a lot of what we went over today speaks to pretty much everything that, all the topics that you would see on the exam. Just some extra things that we didn't get a chance to talk about that would be covered on the exam. And this is information that I'll email out as well with the link. Just some things to touch on: sensory development timeline, just knowing when fetal development of different sensory aspects do you develop over the course of gestation. Cranial nerves was another big thing that they go over on the exam. There were a few questions on that. And then I think one of the speakers actually used the same imaging in one of their talks, but also just knowing fetal neurodevelopment and timelines for that as well. And then also just having a good understanding of certain conditions and what issue with that certain developmental time issues in that timeline that might lead to diagnoses that you would see in the neonatal period. So those are just a few of the things that we didn't get a chance to really go over. I just wanted to point those out as you study for the exam, just to pay some attention to. Otherwise, that is all we have for our second symposium. I can't thank everyone enough for participating, being involved. I can't thank our presenters enough for coming and presenting for everyone. Like Dr. Diaz said, we'll be sending out an evaluation form to everyone that registered, as well as a link to the recordings for the symposium as well. And Dr. Diaz, do you have anything else before we dismiss?
No, just to say thank you, and I'm very, very excited to see our growth as a team. And I know that we will be better and better and better. So thank you everyone for participating, and please look out for the emails, the continued emails that we will be sending. And this is our logo, by the way. Okay.
All right. Thank you, everyone. Have a good day.